Please welcome to the stage Doctors Robert Margolis and Mark McClellan.
And welcome to all of you who are joining us here today. I'm Mark McClellan. I'm the director of the Duke-Margolis Institute for Health Policy. Bob Margolis is going to be joining me momentarily. But first, on behalf of the entire Duke-Margolis team, I'd like to thank all of you who are here in person and many more who are joining us online for being with us in this third annual Duke-Margolis Health Policy Conference on the modest topic of advancing health reform for the next decade. It's great to be here with all of the speakers, collaborators, and colleagues who each bring valuable perspectives and insights to the big health reform issues we're going to address today. And while this is our third National Health Policy Conference, third annual, it is the first National Health Policy Conference for the Duke-Margolis Institute. As a permanent university-wide institute, we appreciate the recognition and support from across Duke, including our well-established and growing Duke programs here in Washington, D.C., as we work together to address the big, complex, interdisciplinary challenges in health and healthcare and the growing and evolving opportunities to do something about them from all parts of our university, and the importance of training future leaders to take on these big challenges effectively. It's hard with the bright lights here, but I do see many familiar faces in the audience here today. For those of you who are, and we thank you for your involvement with us, for those of you who are maybe less familiar with Duke-Margolis, our approach is to combine research teams with deep expertise and policy engagement in key health reform challenges with the academic and educational research capabilities of a global university. So we do lots of research, public events, policy-oriented reports and papers, focus on implementation on a range of topics. If you're not on our mailing list and our social media list, please visit our website. This annual conference is different. Rather than focusing on a specific area, we try to take a big step back to think creatively about some of the major issues that have been persistent challenges to better healthcare affordability and better health for all, and emerging opportunities to address them in more meaningful ways. You might think, well, it's a contentious election year. Shouldn't you be focusing on that? We are, in terms of recognizing that whatever the outcome of the election, these challenges are going to be there. And as you'll hear, there may be some important bipartisan ways to address them effectively moving forward, combining short-term relevance and deeper analysis and developing important long-term reforms. That's how we roll at Duke-Margolis. For more context, please visit our conference event page at healthpolicy.duke.edu. You can get more details on today's sessions and participants, and also you can get our 2024 Issues, Initiatives, and Impact Report, which summarizes a lot of the ongoing work of the Institute. Today, our sessions are going to focus on recent bipartisan developments for state-based leadership to address issues in improving healthcare access and quality, particularly for lower-income Americans, but really for all state residents, leveraging new reforms in Medicaid and other public and private programs to pay for better health, not just traditional medical services. And with respect to the nation's public health, how emerging opportunities for public health, healthcare, and social service programs to work together to enable communities to make measurable progress on improving the nation's health outcome trends. That's our second major topic. Then we'll turn to an assessment of value-based care, which, as you all know, has grown in U.S. healthcare, but still seems to have a good ways to go in terms of achieving its goal of coordinated, longitudinal, affordable care for all, but where there may be some new opportunities to accelerate progress through better data, analytics, healthcare infrastructure that gets away from the grind of fee-for-service medicine. And then finally, we're going to talk about some important opportunities created by unprecedented cross-federal agency actions, as well as progress in data supports and infrastructure to improve the development and use of relevant evidence to inform clinical practice and accelerate effective biomedical innovation, and how to support the changes needed to translate these opportunities into representative clinical trials in a learning healthcare system. Before we begin, I do want to thank our very generous sponsors for providing support for today's events. Joel Marcus, Lynn Zadowski, and the entire team at Alexandria Real Estate Equities, thank you for sponsoring this event today. Alexandria has been one of our steady long-term supporters, enabling events like this one. Also, just a few housekeeping notes. This is a hybrid event. We want to include all of you in the room and the more than 1,000 people who have registered online in our activities today. The entire event is going to be available after 2 on our website. While we only have a limited amount of time for audience questions today, we do want to hear from you, both with questions to add to the discussion and with your ideas about the ongoing and major issues we'll discuss today. You can comment through slido.com using the QR code on the screen, or you can go to the slido.com website with the code HPC 2024, and we are going to try to get in a few live questions in the room as well. And last, we'd like to hear feedback from you on how this conference went and what we can be doing in our future activities. There's a survey also available in a QR link at the back of your program. We really value this as a community effort. So with that, I'd like to welcome the person who has been the vision and providing the ongoing practical leadership and long-term support and commitment to make Duke-Margolis happen, the chair of our advisory board, Dr. Bob Margolis. Bob?
Thank you, Mark, and good afternoon. Thanks, everyone, for coming. As usual, Mark said everything I was planning to say, but said it much better. So let me start by thanking, first of all, our wonderful advisory board that helps in some of the strategic and support for the whole Duke-Margolis Institute. Certainly want to thank Mark and his leadership and the amazing staff that helped put this all together. It's not a simple task to put together a conference such as this, so thank you. And to say, it appears to me, and I think it's fair to say, that we're all here for one very practical and important reason, and are quite aligned in that, and that is that we believe that through innovative, progressive health policy, it's possible to improve the amazing healthcare system that we all live with in America. While there's just unbelievable progress in research and the ability to cure certain diseases, I think we are well aware that there are amazing inefficiencies in the American healthcare system. And through good policy and policy advocacy, we believe that it's possible to develop what we all believe in, which is a more equitable, more high, consistent, high quality, affordable, and patient-centered healthcare system. So I expect that's what binds us together. So as I diffuse the amazing work at the Duke Center and the Duke Institute now, someday I'll say Duke Institute, Mark, it occurs to me that it can be really synthesized into 2 areas that I think are critically important. The first is that with the 85 affiliated faculty at Duke doing amazing peer-reviewed research that can then be translated by the 65 or more research associates at the Duke-Margolis Institute into advocacy, into education, into improving the health status and policy at federal, state, and local levels, that opportunity is something that we all share and is the main goal of the academic side of the Duke Institute. On the other side is the opportunity to educate the next generation of leaders. And with the tremendous support of the leadership at Duke, the amazing demand that we see on the undergraduate, graduate, and postgraduate level for involvement in health policy, learning, and education is critical. And while the first portion, the research portion, is mostly funded through grants and so on, the educational portion is funded mostly through philanthropy. And so we're working hard to build an enormous endowment for the Duke Institute so that we can actually educate the next generation of healthcare leaders, which I hope, after many decades of trying to influence health policy, this next generation and current generation of healthcare leaders will actually make some truly impactful changes. And lastly, thank you, Mark, for putting together an interesting agenda with very impactful and important topics and speakers. And I look forward to an interesting afternoon. And again, thank you all for coming and your support of the Duke Health Policy Institute.
Thanks, Bob. And that's the Duke-Margolis Health Policy Institute. But really appreciate your comments. And with that, let's get started. We have a lot of ground to cover today. And as we go into our first session on states as laboratories for transforming health policy and access, learning from North Carolina, very pleased to be joined on stage by two fellow North Carolinians who are making a big difference in helping states and communities take new steps to address major health challenges. Senator Thom Tillis, our senior senator from North Carolina, among other key roles, serves on the Finance Committee and has been involved in a range of bipartisan health legislation. And then also Secretary, maybe someday, Secretary Cody Kinsley of the North Carolina Department of Health and Human Services has been leading many of these efforts on the ground in North Carolina. I'd like to ask you all both to come on stage if you can. Now, while this may seem like a very North Carolina focused stage, North Carolina received a lot of national attention for the state's work in implementing significant bipartisan health reforms that have made the state an example of the shift from paying for health services to working together to pay for and support better health. These include some federally supported reforms in Medicaid to move towards strengthening primary and community-based care and addressing social factors that contribute to poor health. It also includes a bipartisan approach to expanding Medicaid and to leveraging reforms across Medicaid, Medicare, commercial insurance. And these reforms have leveraged major bipartisan federal legislation, including Senator Tillis's Bipartisan Safer Communities Act. So thank you both for being with you. From working with both of you and your teams, I know these reforms reflect some shared attention and commitment to addressing practical health challenges facing people in North Carolina and other states as well, including a big focus on addressing behavioral health issues. So wanted to start out by asking each of you for your perspective on what do you think about where we are? What are some of the most important lessons from North Carolina's experiences?
Well, I want to start when you referred to Cody as senator, I asked him if he was planning on running again.
One of these days, I think.
We had a good relationship to this point, but
We're going to do a job for a week.
I had before I was ran for the Senate, I was Speaker of the House for 2 terms, and when we were working on health policy, I would always tell anyone who wanted to come into my office and pitch me on something, you have to hit one of 3 levers. You have to increase access, improve outcomes, and reduce costs. If you hit one of them, I'm kind of interested. If you hit 2 of them, I'm more interested. If you hit 3 of them, we're going to implement it. But we also, just for context, and we can talk about good things that were happening. When I came in, it was like, congratulations, you're Speaker of the House, and you've got a $2 billion structural deficit that has to be solved by June. And this was in February. The first thing we had to do is figure out how we just manage the cost situation. And the first thing that we had to do was, in my opinion, balancing the budget by reducing provider rates, which I believe ultimately has a horrible impact on the customer. It's not that I really concern myself that much with the provider, except that we all know that anytime you reduce it, it ultimately, the customer, the patient ultimately suffers. So now, fast forward. And I had to say, all of that was said to say, that is why I was not prepared to expand Medicaid at the time, because we had not yet demonstrated that we knew how to pay for the Medicaid promises that we'd already made. So we stabilized things. We didn't go after the Medicaid expansion at the time, but now looks like it makes sense, and the Republican leaders agree with the governor. They move forward with it. Cody and I have spent more time together recently because of the Bipartisan Safer Communities Act and the behavioral health component, which is the primary reason I wanted to move forward and was willing to compromise on some of the Second Amendment provisions in the bill, because it represents a sea change, a real opportunity to fulfill a promise that was made back in the late 60s and never fulfilled in terms of how do you provide behavioral health care? And how does that relate to everything else that we're trying to do in the state? Well, every hospital should want to achieve maximum benefit of Bipartisan Safer Communities Act so that you can reduce, like Minnesota did, emergency room admissions by 50%. Even if you're not a stakeholder in the hospital in terms of funding streams for Safer Communities Act, you should know what it means if you get that kind of a reduction in hospital room admissions. You're going to have more capacity for more people who can be served. And quite honestly, people who are admitted to a ED are generally not available. They don't have the resources that somebody who's in a mental health crisis have. So Cody, I think, is doing a good job of really stepping back and now implementing the Medicaid expansion. And then hopefully, after we've got the planning grant, we can move on with implementation of the behavioral health component after that. And working together, it's exciting to actually see, blue jerseys and red jerseys set aside and actually work on some things that I think can provide meaningful value to the patient.
Well, it has been a wonderful journey. And, I think just to underscore this point about how do we not just spend money, but how do we invest it? And I think that's been our frame and something I've been so grateful to work with Senator Tillis on, or Secretary Tillis, one or the other, and appreciate Mark's leadership on this, and frankly, the Margolis Center in convening people from really across the spectrum. I like to think that we're all looking at, the problem, and if the problem's an elephant, we think we're seeing it all, but we're not. And we really have to all look at it from a lot of different angles to try to figure out how to solve it. So two big things in North Carolina. One, this roadmap to investing more in value. We leverage our transition to managed care to try to turn our Medicaid system into something that didn't just pay for health care, but paid for the true drivers that impact health over the lifespan of an individual. Really excited to share that we're just now starting to get some preliminary results from some of those pilots that we've put in place. And we're seeing that, and these are our Healthy Opportunity pilots currently happening in 33 counties across North Carolina, some of the most rural counties in North Carolina where the healthcare system was already incredibly stretched. We use Medicaid dollars, and huge thanks to Dan Tsai, who's here, who's been an innovative partner with us in thinking about how to do that in a clever way. To pay for food, to pay for interpersonal safety, which very much aligns with what's in BISCA, and to pay for other things that we know drive health across the lifespan. 2 years in, and we're already seeing from those early kind of prevention investments, an $85 per member per month reduction in cost, representing roughly 14% reduction in cost. That gets back to Senator Tillis's point about how do we control costs within the Medicaid budget, and it's certainly by getting upstream. This is logical to like the random person on the street, right? Is it more expensive to pay for someone who is having a heart attack or someone who needs heart attack prevention? And it's always going to be the latter. And that's why we're trying to do everything through that lens of investing in value. Now, for me, I came home to North Carolina in 2018 after living up here and serving 2 presidents with the real passion to fix behavioral health. That was why I started back in North Carolina, and COVID was a crisis-opportunity in some ways, and that it brought behavioral health to people's common language, and we're talking about it now. And I believe actually behavioral health was a key reason why the North Carolina General Assembly, in addition to that cost control, said we're never going to fix behavioral health without Medicaid expansion. We've got to make a big difference there. And so the enhanced FMAP, or the signing bonus that came as part of the Medicaid expansion package, we were able to put $835 million into behavioral health over the next 2 years. And I don't know if it's been totally announced yet, but I know we're getting—
It's about to be.
Here we go. We're getting another round of funding from BISCA for some co-responder models out in Western North Carolina. Again, thinking about innovative models so that when we're sending people out into the field to respond to what initially appears to be a law enforcement issue, that really is a mental health issue masquerading, we can make sure that we have the right folks there to intervene at the right time and to prevent that person from going to an ED, which is not the right place for them to go, and prevent them from going into the law enforcement space, which is not the right place necessarily for them to go, which saves costs for systems across the board.
Senator, do you mind building on this last point? I know you both have been very involved in getting at some of the root causes of the behavioral health challenges, substance use challenges, other issues that, as Cody said, have if anything, got significantly worse in recent years through the pandemic and beyond. And it's interesting to hear you both talk about the red and the blue jerseys kind of coming together
You
around.
referred
We
to
have
an elephant a minute ago.
right.
The
You got to bring up a donkey at some point. But getting together behind a focus on, okay, how are we going to actually improve outcomes here? That was your point you started with. So we've got BISCA, Bipartisan Safer Communities Act, Medicaid reform, lots of federal and state initiatives coming together. And it does seem like this focus on outcomes and getting legislators, communities to talk about that has changed the dynamic here.
Yeah, you know, and talking about, we become, you were saying if you saw somebody on the street, it would make sense until they get elected. And then it doesn't make sense anymore. You know, part of what we're doing is just being smart on healthcare. I mean, for somebody to think it's a novel concept that needs to be reconsidered, that you'd move up the life cycle to make sure that families have healthy food that produce better outcomes, that reduce long-term costs, and not factor that in. Anybody in business would understand that. If this were a business model, Mr. Margolis, you bring it to it, he'd say it's great, let's invest in it. Business people would. So it's really applying that same construct throughout. The reason I was so excited about the Safer Communities Act, knowing that I was going to get a lot of blowback on some of the Second Amendment provisions that I still stand by, I think they're very solid, defensible, and sound conservative policy, is because of this huge generational, first of a kind, actually, investment in behavioral health. And we got to get everybody to kind of link these things together, because the states that implemented the pilot back in 2017 timeframe just had dramatic reductions. They no longer needed the 100% reimbursement, at least in one state, Medicaid reimbursement, because the underlying cost of Medicaid had reduced. And that's exactly the sorts of things that Cody and the North Carolina administration and the legislature are focusing on now. We just need to do more of it. And by the way, I don't know if you're going to get a chance to ask that question, but let's also be smart about the other things that we learned during COVID. Does any rational person think that we should go back to pre-COVID days of telehealth? And does any rational person think that the federal government, to the extent that we regulate that, should have to reauthorize it every couple of years? Does any rational business person think that it makes sense to say, this is going to be standard operating procedure, you can rely on this, so now go innovate and come up with telehealth capabilities we don't even know exist today? You're not going to get that unless you start just keep pounding, learn from those things, invest in those things, get out of the normal methods of delivery, the ways that you measure outcomes, and then we're really doing something transformative.
And you mentioned earlier, so well ahead of the state expanding Medicaid with bipartisan legislation, well ahead of BISCA. You talked about, Senator Tillis, how the state needed to get Medicaid in order. And there was bipartisan legislation, as you alluded to, that reformed Medicaid, waiver that was approved by the Trump administration, even the pre-Dan Tsai era, that reflected this priority of paying for health. Cody, can you talk, and maybe both of you, I know we only have a few minutes left, about how laying that foundation helped make these further steps and this orientation to whole person upstream care possible?
To me, the fundamental thing that we're talking about is how do we manage risk? You know, and healthcare is a daisy chain of risk mitigation and checks and balances, and telehealth rules this, clinical diagnosis tied, et cetera, et cetera, et cetera. And if we think about cost control from the process control that is, you get why we are to where we are today. This shift to value, in whether it's value-based payment, thinking about what drives health, investing earlier on, is about really tying that risk mitigation to the outcome, right? And look, that's hard. And that's the golden ticket that we're trying to achieve in healthcare, is how do we flip this all on its head and say, you're going to be, this is the aspect of health that you are responsible for as a whatever provider, and so we're going to pay based off that, and trying to shift the system in that place. I think the other thing that is outlining here is a question about, where does public health stop and healthcare start? And that line is, you know, a perplexing thing for most of us. And we've got to, I think far more is in the public health bucket than we realize. And yet public health is resourced in a very anemic way for a lot of reasons. And that's the other aspect of getting upstream to try to drive towards value. The final thing on this is, you know, Mark underscored it. Again, bringing folks to the table around that outcomes conversation and restructuring how we're delivering it wasn't just about building all the kind of healthcare compendium of folks that do that. It was also about bringing a lot of business leaders in and other folks, because these dollars don't get spent and stay in a certain bucket, right? When uncompensated care happens in an emergency department, it drives up costs for everybody else in a lot of other ways. It's the same story about behavioral health driving up costs for systems in a lot of other ways. I think driving towards value is about how do we get all these dollars in a more global sense in the right place.
Senator, any points you'd like to add, as you alluded to earlier, in addition to the behavioral health reforms that are being implemented now around safety and also addressing unmet needs upstream? Cody alluded to programs like Integrated Care for Kids, Healthy Opportunities, pilots that are not yet fully baked. Your thoughts about, you know, we are in a contentious election year. How do you keep the momentum? How do you keep the momentum up for these kinds of reforms?
Well, I think good bipartisan policy is one of the reasons why to try to focus on it. I'm not bipartisan for bipartisanship's sake, but these folks that put on a blue jersey or a red jersey and do things purely on a partisan basis are laying the groundwork for something to be repealed. When an election occurs, then you would expect, I call it political physics, you know, for every action, there's an equal and opposite reaction. So the reason why I've tried to focus so much on bipartisan legislation is I have no doubt that the things that we've worked on have staying power. So I would just encourage everybody to kind of divorce themselves from the rhetoric. We'll put our jerseys on and do what we have to do between now and November, but not allow any collateral damage to this great work that's being done by this administration with the approval of a Trump administration. Let's just fly below radar and get these results out there and continue to focus on getting people into a new comfort zone about, at the end of the day, all that really matters is, have we improved access, have we improved outcomes, and have we reduced cost? Let that be the unifying theme and let everything else fall away. Then I think you can transcend the political ebbs and flows that, you know, our founding fathers are having a blast watching what's going on now, but it's not materially different. We just receive information a different way. It's fundamentally the same as when I was a kid. So let's just get through that and have good policy that speaks for itself. And we'll do the hard work to make it occur on a bipartisan basis, or remember these words: it gets repealed on a bipartisan basis the same way it gets, or on a partisan basis the same way it gets implemented. Just check it at the door. Do what's right for the patient.
Well, and I'll just, you know, add that a lot of credit to Senator Tillis and to trying to, I think that sort of leadership and saying, let's stay focused on the outcome from Congress is so critical, especially for our partners at CMS, who I know, you know, there's a lot of space right now where innovation is happening. I think there's like 84 1115 waivers in the pipeline trying to move, and they're working to try to contort their way to understand and how it could work and check certain boxes. And I think that sense of let's focus on the outcomes is so key to keep them focused on the flexibility to not get stuck in that risk mitigation space.
The one thing I have to do, though, I have to say this, I have to give a lot of credit to Nelson Dollar. Some of y'all may not even know who he is.
Yeah, you should explain to them.
But Nelson Dollar, when I became speaker, Nelson was I was a partner in Price Waterhouse. I don't profess to be a subject matter expert, but I'm really good at finding good ones. And Nelson Dollar was one of those in the healthcare space that was able to bridge the gap and I think get us, you know, start laying the groundwork when we took the majority to really view this on a bipartisan. You made me think about it with the 1115 waivers, because he was the one that really tried to get my conference, who may have wanted to go a different direction, to, I think, a better place. It laid some groundwork that I think Cody, his team, and subsequent administrations have done a good job of building on.
That's a great point. I mean, you started out talking about outcomes, access, and costs, and that's seems like a simple concept, but as you just described, translating that into building a foundation
Hard.
politically, building a foundation administratively, taking steps that show progress along the way. It doesn't happen overnight, but thanks to leadership from both of you and others that you mentioned, Nelson Dollar, Mandy Cohen is going to be with us in a little while. Thanks for the preview of our public health session. You've shown a way to how to make this happen. So really appreciate your being with us today to kick off this important event, and I think provide a note of optimism. Maybe too strong a word, because you're a PwC guy. You're about the numbers and the
Measure
facts
it,
and
execute.
measure it and execute. But a good foundation for measuring and execution for moving forward. Thank you all both so much for being here today.
Yep.
Thank you. Thanks. Really appreciate it. Thank you. I don't know about you all. I think Senator Tillis would make a good secretary too. But so let's move right into our panel discussion on these same topics. I'd like to invite up Alice Chen, Chief Health Officer at Centene, Mary Klotman, Executive Vice President for Health Affairs at Duke University and Dean of the Duke University School of Medicine, and Dan Tsai, already mentioned, Deputy Administrator at CMS and Director of the Center for Medicaid and CHIP Services. So please have a seat. Thank you all so much for being here. You all have been working, Mary, I know a lot in North Carolina, but Alice with Centene and Dan with the whole country's Medicaid programs. You all have a lot of exposure to what's been going on in North Carolina, as well as challenges and initiatives across the country to try to support better care, outcomes, costs, and access improvements. What struck you as from the opening comments that we kicked off with from the Secretary and the Senator about the path forward from here in a contentious election year? Alice, do you want to start?
Sure. I will say, I don't know if Senator Tillis is still here, but what he said about not being bipartisan for bipartisan sake, but actually doing the real work so resonated with me, because having spent the bulk of my career in California, which is across the country, and now Centene is in 31 states, there is far more that is common than divides us. And what I would say is, when you go around and talk to every governor, every Medicaid director, the same things come up. It is behavioral health. It's the mental health crisis. It's opiate use disorder. It's stimulants. So both substance use and mental health. It is maternal child health. No surprise that most states have expanded 12 months postpartum. This was eye-opening for me, having spent most of my career in the Bay Area. Rural health. I mean, those three come up over and over and over again. And so lots more to say on that, but I would say, again, if we keep our eye on the core goals that I think we all have, which is improve population health, improve value, meaning improve quality at lower cost, I think a lot of those dissensions go away.
Yeah. Mary?
So two concepts really resonated with me. One is the concept of a laboratory. And I love that theme, because that implies that we're willing to ask questions, organize an approach, and measure, and really measure and learn from that cycle. And that's not dissimilar to what we do in research. And in fact, the other concept there is that research today is a team sport. And so the idea that you bring people to the table that have complementary skills with aligned goals. And I think that's what we're seeing in North Carolina, which I love. Two great examples. One is NC Inc., which was really a state initiative working very closely, Mark, with your faculty, Charlene being one of them, to develop a program that recognizes that we really need to focus on health rather than single episodes of care. So it's a wraparound program for vulnerable kids that brings together their medical care, their behavioral health needs, as well as the social determinants of health. And that part of care as a healthcare system, we can't do without good collaboration and partnerships locally and with our state. The other great example of, the team approach was what happened in North Carolina during COVID.
Yeah.
We had to work together. We had to get out of our ivory tower and work with the local community and the state, and we saw remarkable successes, and we have to bring that concept forward. The other concept that really resonated with me is focus on health rather than medical care. I've always been struck by the fact that Duke as a health system takes care of 85% of individuals that live in Durham. We should all be aligned around the health of our communities, because it's better no matter whether we're looking at our business or we're looking at health outcomes. And so really moving again out to the community and partnering. I'm really, really excited about Medicaid expansion, but we have to use that opportunity to use those resources wisely and focus on our community.
Thanks, Mary. And Dan, more than 50 laboratories, I guess, 50 states, DC territories. What are you seeing, and how are you thinking about driving this across the country, the kinds of ideas that you heard about in the first discussion?
Well, I really enjoyed hearing the senator and Cody, the secretary, or the senator chat. Because a few things. I think one, so much of what we're all trying to do here really is common sense. And sometimes we get distracted either by not just politics, but regulations, the complexity. Not to say we shouldn't follow regulations, but the technocratic things required to move Medicaid and to move healthcare sometimes seem really daunting, that it's difficult to step back and say, what are we trying to solve for? So things like behavioral health and moving upstream and making sure there's sufficient access, and therefore you need coverage to provide that access when you think of expansion as well as the dollars that brings, or on the whole social determinants or health-related social needs, if you will. It is really common sense to think for many of the people we care for, without being able to provide some integrated support into the care plan and actual support on housing and nutrition, we're not going to keep people from bouncing out of the ED, or even more so with some of the complex mental health and substance use disorder issues there. It is a very intractable set of things that unless you take a holistic approach and think about the multiple parts of the system impacting that individual, we are not going to have impact. And it's kind of like throwing a hammer against the same, whatever the analogy is, and expecting cost profiles to change or outcomes to change, disparities to close without taking another look. So those are really exciting pieces. And I remember being a Medicaid director, generally speaking, Alice, to your point, when Medicaid directors are together, with some exceptions, people are trying to solve the same thing. You do have a budget, you have to live within, but you're trying to figure out how to move a delivery system, improve health of the population, and that's really exciting.
And can I just
Please.
build on these two things, which is, I think there are states that we're in. So it's just interesting. If you talk to Abbott and you talk to Newsom, again, the same things come out. If you look at California and the audacious CalAIM, and you look at Florida, their recent RFP, there's so many similar themes. You have to use the word health equity in one state. You can't use the word health equity in another, but yet the actual work is the same. And I think with the health-related social,
Those common themes are around, let's say, maternal health, behavioral, rural, underserved communities.
social.
Yeah.
And I think that's where the research piece comes in, which is everyone understands that health is more than just healthcare, and yet we need a more intentional and precise understanding of where we invest in order to actually be fiduciary agents of, Medicaid budgets. And so I think some of the work that Dan has been doing about really trying to, and also CMS in general, to say, yes, we believe in this and we need the data. And how do we create these laboratories to actually get us this data to drive policy in a more intentional way?
So maybe pick up on that from each of your two perspectives. So Mary, as you know, leading a medical school as part of an academic center is not the easiest job in the world these days, with all the financial pressures and need for alignment on the one hand, but funding, sources of support from various places. You talked some about the collaborative research that Duke-Margolis faculty, School of Medicine faculty are doing around things like taking these kinds of data that are now available because programs like Integrated Care for Kids has brought the streams together to make it easier to identify kids and families that are at higher risk and figure out what interventions really make the difference. Duke is also leading a lot of work around artificial intelligence applications and things like that. Could you say a little bit more about how School of Medicine and Duke and in this challenging environment are trying to work together to provide that research and evidence foundation?
Yeah, so I think the most exciting opportunity today is around how do we integrate and leverage data. And that's where our health system, our computer science group, our School of Engineering, everybody wants to be in this space, which is great. Now, also, there's lots of, potential problems with that. But recently, I participated in what we call the Duke Institute for Health Innovation. Every year, faculty put in proposals. They were all generative AI this year, as you can imagine. But using it to solve everything from our business and finance challenges to how do you integrate data sets, particularly around social determinants of health that sit out there in our communities with our EMR in a way that we really can provide a provider with the full picture of the individual or family sitting in front of them. So I think we have an enormous opportunity. And that's what, I'm seeing everywhere now with an academic institution. Whether it's in education, finance, or research, using data to really be able to move the needle on some of our most intractable problems. And I think that's the excitement right now.
Yeah, we are that issue about all the data that's out there, increasingly rich, increasing opportunities using analytic techniques and AI to turn it into making a difference for patients, making it easier for their providers and healthcare systems, public health systems to make a difference. I think you're going to hear more about that theme throughout the day. This is one of those areas, though, that's why we had this the next decade focus for this conference, where we're not there yet. And Dan, you've seen lots of states that are, I think, moving in this direction. As Alice said, it's across the political spectrum. Some I mentioned, call out Indiana, more red, Massachusetts more blue, have done a lot of steps to put these data together and power and provide an infrastructure for these upstream models and the kind of evidence that Senator Tillis was talking about. How does CMCS and CMS more generally think about and support kind of the infrastructure and capabilities needed to make these models work, to create the that sound business case?
It's a great question. I think we talk about two things: the health-related social needs part, and then, since we were just talking about behavioral health piece for those examples. I think on the health-related social needs piece, probably everyone here agrees, common sense, you got to go upstream. You can't really think about the whole part of health and outcomes without addressing housing and nutrition. But there is a real question, which is, what is the role of Medicaid in the healthcare system? And what is the appropriate role of other social services at the federal and state and local level? And it took us about a year of working through pretty new policy at the federal level to say, we think that core access to services and coverage is critical, but we also think Medicaid does have a role on housing and nutrition, but it is with some clear guardrails, right? We are not here to take over HUD or nutrition. And those guardrails include making sure that there's a linkage. This is not just about financing what you pay for. This is about how you think about care upstream in a more integrated way. How do you screen for where folks have a range of health-related social needs? How do folks successfully make connections to the right community-based organizations, in addition to paying for that with Medicaid dollars where there's a clinical need, because we are a healthcare medical program. And so we have reframed what that looks like. It's exciting, and it's been very bipartisan. We have states, as you indicated, all across the spectrum interested. I do think that there are a lot of growing pains, and even if they're not pains, there are things that no one knows how to do, right? Which is, you've got, how much does the medical system build some of these capabilities? And when you talk to healthcare systems plans, they'll say, well, the community-based organizations in the housing and nutrition space, they're great, but they can't track a thing electronically. We have no accountability. This is disastrous. And then when you talk to the community-based organizations, they'll say, well, the darn healthcare system over-medicalizes everything and wants to build it all twice without understanding any of the actual linguistic. Both are true. And there's a set of oil and water coming together that's required and figuring out how to do this. What's the role of the health plan versus others? So those are all really important pieces. It's why seeing that laboratory across states is exciting. But we really want to see over the next 5 to 7 years, real progress in figuring out not just, hey, it's cool to cover these things, but how do you do it in a way that actually is scalable, has impact, is cost effective, and moves outcomes at the end of the day. Same is true on behavioral health. It is such a core issue. It's also a cost issue. Not saying that's the only reason why we care about it, but I remember Massachusetts, for one population, 90% of the total cost of care for a particular at-risk population related back to an individual with a mental health or substance use disorder diagnosis, not for their behavioral health services, but for all the other things around that. And we have really intractable issues from workforce to how do we get primary care to be able to do more on the mild to moderate continuum to free up capacity in the specialized system around behavioral health. Those are all things which BISCA and others really help with. But I think it is really open space still for states and providers to figure out how to actually jump in, even with dollars and investments, given how challenging the actual delivery system capacity still is everywhere in the country at this point.
So just maybe a quick follow-up, because I'm going to get back to the rest of the panel on this point. We talked about some of the North Carolina initiatives in this space of bringing together data and trying to get to more accountability and intentionality and sustainability. And you very nicely framed that from a Medicaid standpoint. These are pilots in North Carolina, and many of these efforts, as you were just saying, haven't yet scaled up successfully. Cody, Secretary Kinsley talked about some early evidence from the North Carolina experience. What are you seeing so far about sort of promising directions, or maybe if the evidence isn't all there yet, what would you like to see more of? I'm going to go back to Mary and Alice on this.
Yeah, I mean, very briefly, I think what Cody has shared about what they're starting to see in North Carolina is really exciting. And I think there are nascent elements of that all across the country. If you fast forward 5 years, I'd want to see clear data that states and managed care plans, others involved in doing this have, and actually pointing out where interventions have an impact, not just on cost, but value also includes quality, outcomes, and a range of other things where we have significant disparities. We have great hypotheses. We have early indicators like in North Carolina. Building on that evidence so that as we think about the next generation of 1115 demonstrations, they are supposed to be demonstrations you have to evaluate. What is the stuff we can actually build on and the thesis we grow on versus it would be a disappointing place in 5 years from now for a bunch of 1115s to still be going out around cool health-related social needs, but it's a scattering of 1,000 flowers blooming because everyone's like, it's cool, but no one knows what works exactly and how do you actually bring those parts of the delivery system together. So I heard Cody drop a bit of our 1115 negotiation. You put a little anchor.
There was I saw that too. Yeah,
the tension always is as common sense as things can be at the ground at the state level, the federal level, we're trying to form policy that can be fairly and consistently applied across states. What that means is sometimes we have the opportunity to do incredibly big things like this new entire framework around Medicaid's role, but it also means sometimes it constricts where there's a lot of innovation, and finding that balance is difficult. We are having an ongoing chat about that that's now in public now.
A friendly chat, I'm sure. Yeah. And Alice, yeah, I do want to go to you next on this. So you're not in 50 states, but close, 31, different program in each state. And one of the things that people here might not know, but that you and I know, is that we work together. Duke-Margolis supports the Healthcare Payment Learning and Action Network. That's a CMS-supported public-private collaboration that is increasingly focusing on how do you help states align and how do you help national payers align on evidence and standards for making these kinds of approaches to care the norm. We're definitely not there yet, but maybe you could build on Dan's comments from the private insurance perspective, because you all are a critical. I mean, Medicaid is now a private accountable, or heading in the direction of accountable Medicaid managed care programs for administering all this.
No, absolutely. I was thinking in terms of the health-related social needs. I'll talk about STCs first, which is in terms of HCP land, the focus on states as laboratories and the fact that, oh, the 1,000 flowers blooming, that there's this intersection between policy, program, the private sector, where if the policy signal is kind of like, yeah, that's a good thing, you get that 1,000 flowers blooming. That's what Centene across the 31 states. When I walked in last January, that's exactly the term I used, 1,000 flowers blooming, because no one can dispute that it's a good thing if someone has diabetes and doesn't have enough food and doesn't have a refrigerator for their insulin and can't get to their PCP, that by providing those things, you are likely to improve their health and prevent them from ending up in the emergency room. And there's actually evidence on that. We need more evidence like that. But I think because the policy signal was kind of like, yeah, this is a good thing, you had 1,000 flowers blooming. And we are really at Centene trying to step back and say, starting with food as medicine, how do we really think about, again, intentionally, where do we invest for what populations at what level of intensity, and partnering with researchers to figure out how do we both have 31 laboratories, but then aggregate it to a Centene-wide level for 13.4 million Medicaid members. What I'd say is part of that in terms of the evaluation piece is metrics. And metrics end up being kind of the foundational element of a lot of this. How do you know something's happening? And then tying it back to value-based care and knowing that we're all trying to improve population health. I wanted to go back to the STCs, which I think has been really
and that's state transformation collaboratives that CMS is supporting in a number of states, including North Carolina, to try to get at these issues of moving from fragmentation to effective alignment.
Thank you for helping me avoid acronymies. I thought I'd gotten away from that as a physician and as a missionary now. But I think the state transformation collaboratives are a really unique part of HCP land because they are state-based focused teams in not just North Carolina, but California, where I actually participated in when I was at Covered California, Colorado and Arkansas. And what's really both a little bit surprising, but in the end not surprising, is that they've all landed on measure alignment in primary care. And primary care in particular touches on behavioral health and on health-related social needs in a very deep way. And I think some of the work across those 4 states has great promise to figure out how do we actually go from this theory, like we all agree, bipartisan support on the topical areas, but how do you actually get down and actually make it happen for patients and communities? I think STC, I would encourage people to go take a look at that one.
Yeah, so and those are state-based efforts, but you're also, Alice, part of an effort with the national health plans to, to Dan's point, we want to get to more systematic and evidence-based ways of moving forward on these approaches, but it may be challenging if that's different in every single state. So balancing to I guess the friendly discussions you're having right now with Cody, balancing the state innovation and finding reliable, consistent ways to move forward. And Mary, I'm going to come to you with administrative burdens on clinicians in just a second here to bring that down. It seems like there's a national as well as a state process needed. Yeah.
No, and I'd say I think I just want to give a shout out to the MAC QRS again, given that 70%.
You just did another acronym.
The Medicaid quality rating.
You sound like a full-blown Medicaid person now.
Well, I spent that's my first love, Medicaid. But I will say, I walked in as like, oh my gosh, every state has a different set of measures, and like 70% goes through managed care now, but we're still using kind of these fee-for-service framework. So the fact that CMCS has put out this Medicaid quality rating system for health plans and did a parsimonious set of core measures. Thank you. Like rather than, doing I think 100 or 60 that we currently have with NCQA, like really starts laying that foundation. Because again, to your point, as a national health plan, I have these internal conversations with our teams, like, can we have a standard approach? And like, with whom? Like
Yeah.
standard across Centene, standard within a state, standard with like, this type of provider, F2HCs, like there's so many ways to standardize that it becomes really challenging. And so when we have a signal from CMS around here's what we want people to focus on, that really starts being that catalyst where things can really organize.
Yeah, so Mary, as we've talked about before, when we lived in the fee-for-service era, it was kind of nice that there were CMS, really Medicare standards that really governed all of the individual fee-for-service claims. And while clinicians, I think, felt burdened sometimes by all the coverage processes and administrative processes around the claims, at least there was one set. We've talked a lot about some of the challenges and concerns that we hear from frontline clinicians in the North Carolina State Transformation Collaborative, this public-private effort. Their number one concern is they agree with the goals here, but it seems so burdensome to them to see different measures across different health plans, inconsistent supporting data sharing. If you can't get the data to identify which of your patients are at high risk and which ones are most likely to respond to different kinds of interventions, you're kind of flying blind, and that's not necessarily consistent across plans. I know we've worked at Duke on some ways to address that through things like AI assistance and reducing administrative burden, but maybe you could talk a little bit about what you see from kind of the frontline standpoint of needed to help address these administrative burden concerns, which are real.
Burden, and then there's health system burden.
Yeah.
And it's there in both arenas, the
Yeah.
costs that we're putting into the system just to meet the different reporting, they're enormous. So we need to get those costs out because that's all related to then resources we can use for better purposes. But if you think of the individual provider, I mean, burnout is real. It's real in every profession. It's real in every subspecialty. It was before COVID, but it's markedly accelerated with COVID. And, there are lots of reasons, but the number one reason providers will give you is the burden of administration. And of course, we all like to blame the EMR, but it's not just the EMR is real. But on top of that, the requirements that they have to go to justify the care that they provide, it all ends up on the same shoulders and it results in burnout. And we have to take that serious. That is a workforce challenge that has gotten worse rather than better. But the other thing I was thinking about when we were talking about innovation and, how do you engage a broader workforce? So, we have 2,800 faculty. They're brilliant. They have ideas. You tap into some of them, but that's kind of the tip of the iceberg. And how do we engage them in problem solving in a way that really sort of taps into a very talented workforce? How do we create incentives for both providers, but also our data scientists to want to get in the same space and solve the same problems?
There is a lot of funding that goes into biomedical research, clinical trials, and things like that. But to help guide and to get to Dan, you brought this point up about what's the evidence that can give us confidence in moving forward and more systematic and built-in ways in these models, getting beyond pilots to being the new future healthcare system. A lot of efforts underway through pilot evaluations, learning, and things like that. But to Mary's point, it seems like we're not really tapping into being able to feasibly do research or at least implementation science support for these transformative changes. Dan, Alice, any thoughts about how you're seeing the evidence problems? And Dan, I think you already talked about this a little bit, but it is a key challenge to overcome the inertia and get to
It is
more
for sure.
progress.
And I think there's both the data and research and evaluation, but also I feel like in many ways, there's still, in early days here, you've got a primordial soup of, or 1,000 flowers, or whatever the analogy is, all sorts of it, without even clear heuristics of different approaches that you can start to categorize and therefore measure and have a schema between. So I think those are really important pieces. Mark, if I might, one thought I had, which is taking one step back for a sec. all of these things are absolutely critical that we just discussed. From our standpoint at the federal level, there's a little bit of a hierarchy of needs as well. And so in the Medicaid space in particular, especially with everything we've been going through in the country with Medicaid renewals after the COVID and the public health emergency where people's coverage was protected, we have a fundamentally new spotlight on how easily eligible people can make it through the Medicaid application and renewal process. And because coverage is the first thing. If we don't have coverage, all the stuff that we just talked about, we don't even have. And some of the red tape and challenges there. And, I think in North Carolina, not only is North Carolina expanding Medicaid, they've done a very good job around streamlining things and reducing that red tape. So in a matter of months.
And that's not only an issue for Medicaid alone, but for this more integrated approach to programs, building in, I mentioned Indiana too, but
Sure.
building in cross-cutting infrastructure that takes out the administrative burdens that go beyond healthcare alone in trying to achieve these goals.
And so those are really important things. And that's why we, from a federal standpoint, we are pushing to have the Medicaid experience of eligibility enrollment be much more similar to what any of us would accept for ourselves and our families versus every 12 months, a third of people drop off coverage for some unknown time of 1 to 4 months before they come back to coverage. That is not a particularly good thing for behavioral health, for health-related social needs, for any of that.
Maternal health.
Any of that. And then once we've got that, the other piece that is a string attached and how we've thought about the coverage of health-related social needs is we won't be able to be effective unless there is actually sufficient underlying core access to clinicians like primary care providers, OBGYNs, mental health, and SUD, substance use disorder providers. So a carrot, a string attached to our 1115 demonstrations in different states has been, we'll give you this new authority to test coverage of health-related social needs, but in exchange, we're expecting the states to increase their base and underlying reimbursement for Medicaid providers, particularly upstream for primary care behavioral health, to emphasize that you need that underlying core network of providers in addition to the really innovative whole person care pieces. If you have the latter without the former, you'll do some good, but we will not be able to address some of the overall health outcome pieces that we're trying to do.
Can I just say that
And this, I'm going to go to Alice next. An important point to build on. We've tried to cover a lot of issues that I know are important to the audience here. If you do have additional comment or question, please use that Slido website or QR code and let us know. So Alice, sorry, back to you.
I hope your message gets out because actually it's interesting that Maslow's hierarchy is something that we talk about all the time, and going into an RFP or talking to our states, saying, it is really important technology. You need the really solid cake and hopefully nutritious cake before you put the icing on, right? And so a lot of times we're asked for innovations, that's great, but what is the access? What are the core quality measures? I think if we can also have the Medicaid agencies come in and really prioritize that, that also helps then the payer.
Are you seeing that happen, or what would help accelerate that?
I think actually the QRS would actually help accelerate it. If that were front and center on all our fees, that just is a signal to say we want these core things in addition to the innovations and the apps and the different platforms. Just a quick thing on implementation research, which I think is critical in this area. I spent a decade at UCSF, and my experience with implementation research is it's this. There's program on one side and research on the other, and there's a very little tiny precipice where a couple people can balance.
Yeah.
We need to create a plateau where people there's some core researchers, core programmatic people, but a whole continuum of people who are really thinking about how do we evaluate this and do this in a not perfect, not controlled setting. When I was working at eConsult, we had a really amazing researcher. We had a survey where the last question was, what else do you want to add? 8 pages of 10-point font comments. We started addressing them in real time before the survey closed out. We still were able to publish in JGIM, but that was not a controlled setting, right? Because things were changing out from under. That kind of mentality in the research world and the academic world, I think would really help.
I was going to come back to a later session this afternoon, but just to push a little bit on what that looks like. So there's a lot of implementation research that I think is along the lines of, Mary, you and I have talked about this, of, we've got a grant. Let's add in a few community health workers. Let's see if that, or a food is medicine program. Let's see if that impacts, diabetes control, hemoglobin A1C levels in certain patients. But that's not really the only question that matters, right? There's workflows, there's ongoing financial sustainability for these programs. We're trying to build out these research capabilities at Duke, but really appreciate your take on what the future opportunities are here.
What are our research sponsors willing to fund? And this has not been an area that is a top priority in most of the institutes that fund the research intensive academic institutions. So without that, your faculty are limited in what they can do. Now, health systems, if they're smart, are investing. And, we see some, but right now the finances, are challenging for most health systems. But we know the way you really stimulate research is you provide an opportunity for funding, and smart people will go after it. But we've always seen that the implementation side of research is kind of an afterthought in at least many of the sponsors like NIH that we generally deal with. The other issue relative to workforce is, a really important issue. And one strategy is to increase the pay, but the other strategy is to think about how do we develop that workforce.
And the composition of that workforce too.
And what are, how are we working, particularly institutions like Duke that, train thousands of health professionals a year. How do we work with our communities better to really develop these career paths that are so needed in the community, behavioral health certainly, but a lot of the team members, and we're just starting, I think, institutions just starting to take that on as a win-win. The more we do that, the better workforce strategy we'll have for our own institutions and for our community.
And that includes a range of members of the healthcare delivery team, community health workers, et cetera, that they've not been.
I mean, we need, the MDs are certainly kind of the tip of the iceberg, but it's all the other healthcare professionals that are needed.
Yeah. Dan, any thoughts about getting that implementation science and implementation support work broadened out? I know you all have done a lot of work with states, with CMMI, with other agencies.
It's important. There's a lot of non-shiny work that happens that's really important. Once a state and we or others approve and launch giant programs, I think so much of this is in the execution, the figuring out what works, what doesn't work, refining. And so all I would say is a very large portion of our team's time and what we're working on with our state partners are all on the back end. What's working, what's not, how do we negotiate refinements to that? That's really important. I don't think we ask for clear evaluations. We're kind of relying on the states a little bit. Alice, your point resonates. I don't think the research, the evaluation, the program design, the implementation, all of that, I don't know that there is as much structure and proactive thinking right now about how to figure out and test and structure what exactly works on all the stuff that really matters for execution. Even a basic thing like I was with a bunch of with our HUD colleagues with a bunch of housing providers that are all participating in Medicaid waivers across the country. Each one of them was highlighting, well, in North Carolina, they do it this way. This health plan does it just this way. All these various like random things that add administrative burden. But no one really had a perspective on which one of those approaches would be better, like paying upfront on a PMP per member per month basis to a CBO to do stuff versus fee for service on the back end with a fee schedule without myriad questions that are all absolutely legitimate that in the healthcare delivery space, we have a starting point for. But we have randomness not for the sake of policy intuition, just it's what happened. And I think there's opportunity to be much more thoughtful and structured across the country, I think, in tackling which policies and how do we measure and how do we figure out what actually works in the execution.
We are about out of time, and you all have gone from the very high strategic level of advancing population health, paying for health, to the nitty gritty, but essential infrastructure issues as well. How do you develop evidence on what works? How do you bring down the administrative costs and burden of moving to these kinds of systems? It's been a great discussion. Any quick final thoughts that you'd like to leave us with?
I will do my plug. Medicaid, Children's Health Insurance Program, it's one of the coolest things out there. If you're a provider, it is, we've come a long way in how people think about Medicaid and CHIP, the Children's Health Insurance Program, as not just part of the safety net, but a bedrock of what the delivery system looks like. And so we're excited about that. These discussions show where we can innovate and think through a lot of pieces, but at the end of the day, Medicaid is great. And we want to make sure people are covered, they can get access, and we do a lot of this sort of innovative stuff to actually improve what the health of our covered people look like.
Thanks, Dan.
I'm just thinking about that. Medicaid is great. I'll bring that home. But I am excited by what I've seen happen with the Margolis now Institute, is getting the next wave of passionate researchers, faculty, students that really want to take on some of these challenges and understand, you know, that it is hard work, but they want to do it and they want to advocate for a better system. And so seeing that take off, I'm really excited about that.
Sure if this is the right target audience, although Dan is part of it, but I think as Centene, single largest Medicaid plan, marketplace plan, and big footprint in duals. Again, the signals we get from the policymakers, and the more that we can signal that we're interested in population health as a whole, as opposed to approaching things by line of business or by state, like that's going to be what moves the dial. And then just to close on kind of future, this is the conference I'm looking forward 10 years. And that whole Bill Gates thing where we overestimate the change in 2 years, but underestimate in 10 years. I mean, AI and data are going to be huge for so many good things. And I really do worry there's a potential, as with all things, that it may worsen disparities. And so really asking people to keep an eye on, like, not making sure that in the future, people who are well off have the perfect blend of, clicks and mortar and virtual and AI, and then poor people just get like digital. Like, just let's think about how we actually move forward in a thoughtful, intentional, inclusive way around all the innovation that's going to happen.
All right, that's a great last word for this session.
Alice.
Thank you all so much for a really excellent discussion. All right. Not only an excellent discussion, but our panel did a nice job of transitioning to our next session on public health and healthcare as partners. As Alice said, really getting at population health. And so I'd like to welcome two healthcare federal leaders to health and public health federal leaders to join us in this discussion on the stage. I think they're both here. I see, oh, I do see both of them. So John Blum, who's Principal Deputy Administrator and Chief Operating Officer for the Centers for Medicare and Medicaid Services, CMS, and Mandy Cohen, welcome back, another fellow North Carolinian who's currently Director of the Centers for Disease Control and Prevention, but your ears were probably burning during our first session earlier. Thank you so much for being with us today. I know you both have very busy schedules, but the session title, you heard some of the previous discussion. What do you see, given all this interest in bringing public health and healthcare together around population health, and we've talked about it a bit. I hope we're going to get deeper to it in this session. Some of the challenges facing public health organizations today. What do you see as some of the most important opportunities for your agencies working together? No offense to CDC, but my first speech to my staff at CMS when I became administrator was, CMS are the nation's largest public health agency. And actually one of my advisors pulled me aside. I just come from FDA and said, you realize this is under the Social Security Act, not the Public Health Service Act. But big agency, how it pays makes a huge difference, as we just talked about. On the other hand, it's hard to see us getting to better population health without leadership, guidance, analytic insights, et cetera, from public health, which has been challenged too. So what do you see as the best opportunities for you all to work together? And that's not meant to be a softball question, as I know you all are already working together in a lot of ways. It's meant to be, I think, a really critical question for the health of the U.S. population for the next decade.
Um, uh, Thank you, Mark. Just to start off, I think one of those silver linings to the past 3.5 years, 4 years or so is that CMS learned much more rapidly than I think during your time, that we have a real vital role to play with how we support the public health response. Things that we put in place was nursing home vaccine mandates for all healthcare workers. That was the only mandate that really survived because we had to keep the healthcare system open. And so I think it was a kind of turbocharge to the vision that you had during your time at CMS, that we're not just a payer, that we are supporting the overall public health response, that our division within CMS right now, the CCSQ, that thinks about safety, quality standards, and healthcare measurements, that's one of the biggest centers for CMS right now, which really shows that we are no longer just a payer, no longer just setting health plan standards, for example, but we're really trying to help support CDC, the FDA, and healthcare systems think about public health safety.
Well, hi, everyone. Good to be here. So I think, first of all, I love how much North Carolina talk is going on in here. I'm so proud of North Carolina and the work they're doing. And I want to thank Duke-Margolis for continuing to be a partner and in all of that work from 7 years plus that we've been working together in North Carolina. And I think there's a lot of really important outcomes that we can see there. Congrats to Cody Kinsley, who has taken over the helm there, is just really driving the work forward. The healthy opportunities pilots and those results, those are really important. Sorry, and before we get on this tangent, I just wanted to
it's all related, right?
Because look, we are learning some important lessons, and then our job is to codify that in systems across on the federal level. So we learned a lot of lessons about how to work well together when we invoke some federal emergency authorities. Well, okay, that moment is over, but we know we still need to operate as one team. So we can say those words, but I hope what you're starting to see between CMS and CDC is us move together with joint ways of holding folks accountable for keeping our communities healthy. We say it, but we need to use those tools together. And I want to thank John and the team. I think you're seeing that in the first time that we've used CMS authority in the IPPS rule that just came out as proposed rule last evening. I'm sure all of you have read it overnight.
Read it already.
So this for hospital,
so it's
roughly hospital payments in Medicare.
Exactly. So using hospital payment rules to say we need hospitals to continue to collect data for public health purposes, using CMS authority, but that will be data that we will use, again, de-identified data in an anonymized way to understand what's happening in full communities, not just in one health system, but so that we can give folks real information about what's happening in their community related to, now it's going to be COVID, flu, and RSV to start with, but how do we build from there? So that I think you are seeing us taking like a real step forward to say there are a lot of alignment. Then move to the quality metric space, right? Again, these are ways in which we can help prioritize. The last conversation was great in saying we have a lot of quality measures. They're not all as important, right? Public health can help focus. What are the really most important health threats from a population and community health perspective that we're seeing? And is our quality system actually reflecting that? So you're seeing some changes in what quality metrics what do we need to retire? We've actually, thank you to CMS, have retired a few metrics that didn't make sense anymore from a public health perspective. And we've added some new ones that need to be lifted up more. So I think those are two places. And then the third continues to be all of the data work that we need to do. One is on the authority space, but I've been saying there's no new magic money that's coming. There's no additional congressional authority, certainly not this year. So we have to do what works and is continue on this path that we've been on, which is working on this interoperability and using the tools through ONC and the work Mickey Tripathi and that they're doing. So everyone's got to be using TEFCA, right? So in public health, we're trying to leapfrog over some of our antiquated systems, go right to TEFCA and move past the point-to-point solutions and into that more connected network, making sure that we're doing electronic case reporting and that we are using FHIR standards in public health. So those are, core stuff that we've been hearing in the healthcare side for a long time, doing in public health to make sure that our data is interoperable, and we can do it in 2024.
So it's a great vision, and I want to thank you both because you and your staff contributed to a recent provided some input for a recent Duke-Margolis National Academy of Medicine report on short-term actions to help advance the nation's health through public healthcare collaboration. And as you all both mentioned, central to that was better information sharing to inform accountability and to enable more timely activities. And Mandy, you were touching on this at the end of your comments about things like it's hard to do health policy without getting into acronyms, but TEFCA and sort of interoperability standards, that we have better electronic records now thanks to CMS payments and regulations behind these standards that the Office of the National Coordinator for Health IT is developing, that are intended to make it easier to get data securely and, as you said, in some cases anonymized from electronic records straight to where they need to be used to inform these local responses. Public health and healthcare overall during COVID weren't generally able to exchange that information in a timely way. You mentioned for respiratory viruses, COVID is one of them, but there are other big threats now too, where we have effective diagnostics, effective therapies, effective vaccines, where informing these issues at the community level across healthcare and public health would be really helpful. I don't want to get too much into the minutiae here, but I mean, this seems like the connection between Senator Tillis started out by saying, show me the results. Can we actually build a business case? Can we actually build metrics to support how healthcare, public health, and other programs working together can improve outcomes, whether it's for respiratory infection threats or opioid use disorder or obesity, prediabetes, diabetes. How is that moving forward? And this is just, as you just underscore it, there's not a lot of new funding for public health right now. There are not going to be any new authorities at the federal level, and in some states, authorities are getting less. And John, to your point, I'll come to you next on this. CMS can go ahead with regulations to create standards to require certain kinds of reporting, but that's much easier to do if the healthcare providers feel like they're getting something out of this. It's not just like putting more effort into a black box, more administrative burden. We heard all about that in the last session. So this seems like a challenging set of issues to address, but it seems like you're trying to make progress here.
But just to follow up Mandy's comments regarding the data work that we did with CDC, there was two core principles that I think Mandy and her team really drove hard on. Number one was that you want data collection going forward to be least burdensome really as possible. And so part of our vision going forward is that we want to use the systems that we have in place to build upon rather than building new systems. And during the COVID pandemic, we had to build new systems given the urgency. But going forward, the vision will be that we're taking away burden from the healthcare systems, but still collecting the information. So that was the first key innovation. The second key innovation that we really push hard on is that the system should flex. And there should be core reporting for just kind of baseline. But as the situation changes, that we need to have the authority, that we need to have the ability to collect richer data. The third principle is that data has to be shared back to health systems so they can take action. And so I think in the first iteration during COVID pandemic, we had a system that was fixed. We had a system that took a lot of staff time to collect. We had a system that didn't really share that data back to healthcare provider that was actionable. And I think the vision going forward is that we're going to change those three pieces. Minimal burden, system flexes during times of crisis, and then third, that data should be shared back to communities. I think the other area that we need to really push hard on too is making sure that our value-based definition, defined broadly, is not just focused on what are the metrics, what are the measures for how we save costs. And I think the vision that we have going forward is that part of the infrastructure that we need to build is that value-based care needs to be defined differently. So it's not just about better efficiency, better cost control, but it's really about building more resiliency throughout the healthcare system. I think the core learning that we learned during the pandemic is those populations that suffered the most are precisely the populations that value-based care should be taken care of, those that have ESRD, those that have multiple chronic conditions. I think we also need to reframe how we collectively think about value-based care as that is part of the one of the core missions.
Mandy, is public health have the infrastructure to meet healthcare in those principles?
We're working on it. So we're not all the way there yet, but I really wanted to underscore John's third principle, which is public health has to make sure that for any data that we're collecting, there has to be value back to the clinicians who are collecting it and to the communities.
And
So
that data is increasingly coming from healthcare providers with
That's
more
right.
lab tests
That's
and,
right.
and upstream interactions. Yeah.
Exactly. So we are not just cannot be it cannot be a one-way street where data is coming to public health and then it is sitting there until some magical paper is published. And so this has to be about real actionable data. So I hope you are seeing that already. Where we have that data, we're sharing it in real time related to COVID, flu, and RSV when that as we're getting it, so that folks can actually know what's happening in their community. I will say when we were leading through COVID in North Carolina, one of the reasons I think we did as well as we did was because we had great visibility across all of our hospital systems. So if there was an open ICU bed here or there was extra vaccine sitting there, we had that visibility and we could move resources around in real time. And that's what I think folks want to get to. There's plenty of places for folks to compete on. These public health indicators aren't the place for competition. And I think that's what we are establishing the framework to make that possible with the least burden, again, building on those same standards that health delivery system, that ONC and CMS have invested in for years. So it's not like we're saying, oh, public health is a special snowflake over here. No, it's the same stuff we've always been doing. And so it really cuts down on the burden. So hopefully they won't see something that's burdensome. They'll see something that's value add. And I hope it aligns with what we want to pay for. And so I do want to put in plug with that, also moving in a direction of saying, right, if you want to be accountable for a population, that's public health, right? And so how do we make sure that what we are expecting on the outcome side, again, with quality metrics, is aligned with what are the priorities for keeping the population protected and healthy?
Well, it is, accountable for a population is what public health aspires to. It's kind of hard for public health to do it by itself with the limited resources and authorities, as you were alluding to. But you also talked about your own career path, and to get to this point about paying for health and how that can support public health healthcare alignment. I mean, you kind of live that in North Carolina. We started working together in the state. Duke-Margolis and Mandy Cohen, Secretary of HHS, came in around the same time with this move that we've talked about in the earlier session from Medicaid that Senator Tillis had budgetary concerns about, and it was really focused on services, not outcomes, to implementing steps. You did it in healthcare, public health collaboration in the state, which was, I think, widely recognized nationally as a potential model going forward during COVID. What do you see as the next steps from where you're sitting? And then John, I'll come back to you too, around CMS goals for really broadening the availability of value-based or accountable, whole person coordinated care, which has accountability for population health outcomes. And getting to public health that's integrated with that, and that is maybe also more accountable for health outcomes.
Yeah, so I want to link two things together. So one, we just wrote a piece that just published in the New England Journal last evening that outlines 3 areas in which I think we can continue to invest in a very practical way to knit together public health and healthcare. Data infrastructure, the clear prioritized goals, and clear roles and responsibility and accountability. And that's what we did in North Carolina. So I want to link it back to how did we do that in North Carolina? One, we invested in one unified statewide platform that linked healthcare and social services together. It's called NC Care 360. But having that platform when we went into COVID and as we were doing some of our Medicaid transformation was really important, right? It gave us visibility, it gave us data exchange, right? All of this that we're still talking about now, and as we get into the public health space. The second is we were prioritized in what we were focused on, right? We said we wanted to focus on outcomes. We were clear on what those were. And we said everyone's responsible, the payers, the providers, right? As well as the state. So we were clear on that. And then we built those clear roles and responsibilities. And we said, and you're accountable, and here's when and why. So I think it's the same playbook that whether we're running it for integrating public health, Medicaid, mental health and social services, or we're thinking about the bigger picture of alignment here. Got to have data. It's got to be interoperable. You have to have clear accountability for and agreement on what goal you're trying to aim after. And that's again where I think there's good CMS and CDC alignment there.
John?
I think there's 2 things to add. I think number 1 is how we are operationalizing value-based care today, I think needs to be rethought. And so in today's world, that value-based care largely is a kind of separate business model for how a health system might win in this current reimbursement world, or how it competes with the health plan, et cetera. But I think when you really see value-based care done well, and we were in Arkansas last week, where there was a very strong community that gets together to think about shared resources, shared goals. And I think what CMS needs to think about more is how we build programs, models that really incent that community coming together, thinking about population writ large, not thinking about which patients belong to me versus you for that shared savings win, but to really think about how we incent that much stronger community coming together that can have the conversation that Mandy described, how we share resources, how we shift resources during times of need. The second thing that I think we also need to do is to think about how we decrease the costs for those that want to enter value-based care. And so it is hugely expensive to come into these programs, to build your data sets, to build your care coordination programs, to really compete over that care coordination role. But if we can lower the cost, and I think this is the role for government long-term, is to really create more shared resource. How do we share
More infrastructure, what you were talking about before? Yeah, can you say a little bit
Exactly.
more about this? Yeah.
how we share data, how we collect data. But I think that's a role for government going forward to help to enable more of that collaboration going forward.
Well, I want to thank you all for your time with us. I know you're both extremely busy, but it's really interesting to see the progress that's happening on CMS, CDC. I should add in ONC and there are other federal agencies that matter too, that could contribute to this joint effort. We're going to keep following up on these topics for the rest of the day, and hopefully some continued collaboration with both of you in our work at Duke-Margolis. Thank you all so much for being here.
Thank you.
Great, thank you. And we are going to go right into our further discussion of the topics that John and Mandy so nicely teed up. I'd like to bring up our panel with some additional perspectives on public health, healthcare, community services as a team sport. Joining us on stage are Georges Benjamin, Executive Director of the American Public Health Association, Fred Cerise, who's President and Chief Executive Officer at Parkland Health in Dallas, and Karen Dale, who's Market President at AmeriHealth Caritas, District of Columbia, and also co-chair of the Health Equity Action Team for that CMS-supported healthcare payment learning and action network that we talked about before. Thank you all for being here with us today. So you all just heard Mandy Cohen and John Blum talk about new data capabilities, building an infrastructure, and building some accountability really around community and population health, using these federal programs to support stronger, more resilient communities that can work together better on advancing population health goals. You all have been committed from different starting perspectives to bringing these kinds of ideas together throughout your career. So I just wanted to start with asking you from your respective vantage points, what do you see as the key opportunities here along the lines that John and Mandy discussed, and some of the key challenges and how to overcome them? Georges, you mind if I start with you?
Sure, Mark. Thank you. We know exactly what to do. This is not rocket science. On my desk, I have at least 2 stacks of reports that have come out pre-COVID, during COVID, and now post-COVID, which all say the same thing. And at the end of the day, it's infrastructure, and collaboration. The infrastructure issue is having the political will and leadership to do it. And the collaboration issue is not that we don't exchange business cards. We always say you never want to exchange business cards in the middle of a disaster, but we always exchange business cards. And then we let those collaborations go cold. So the real issue is, how do you keep those collaborations warm and engaged on an ongoing basis, so that when you need to scale them up, you can scale them up, and when you need to bring them down to a different level of engagement, you can do so.
Fred?
Yeah, I will echo that. In our world, health system world, we talk about integration, but we tend to talk about physical health and mental health, or primary care and specialty care. But we really don't talk about healthcare delivery and public health is that much at all. And so I think, getting to know, it sounds very basic, but getting to know those different worlds, because they operate in silos apart from each other. I would bet most big health systems, many of them probably don't know who their local public health director is. So learning that world, planning together, we do a CHNA, a community health needs assessment. We do that with the local public health authority. So I think that's the first part. It sounds pretty basic, but that's where I'd start. Challenges. We operate different businesses. In health systems, you're running a business and you're pursuing the things that are going to pay you to run that business. It's less obvious how those public health goals get you there, right? I mean, it's easy to see if I'm going to do a knee replacement, how I'm going to get reimbursed for that. Mm-hmm. But I have to think a little harder about if I'm going to pursue my public health goals, which a lot of systems will advocate. They'll say that's part of their mission, is to advance the public health. But then you've got to think about what you're doing today that you can apply to do that. So things like community benefit, or some of these, flexible payment systems, Medicaid waivers and whatnot, and how that applies to the public health goals of prevention and treatment. I mean, the opportunities are there, but it's something that's not front of mind in most of the health system until you get into the public health emergencies. And then everybody springs into action and you can do it. And it's amazing what you can do in the middle of an emergency, right? But how can we apply those things that we know, sharing resources, sharing data that we'll do in the midst of an emergency? How can we apply that to solving, respiratory infections that are happening, sort of
behavioral health,
substance use, to sort of those things?
Yeah, Karen?
The 2 challenges that I see are, first, around inclusion. We are sometimes quick to take actions based on our own position and power. And it is really important that we involve the community, not just the representatives of the community, but those with lived experience. We learn so much about how they navigate where we have failures, and it gives us a great opportunity to be more humble about where we are. When we listen to those voices, we get their buy-in. That helps us to have much more compelling solutions that the community has a stake in and ownership of. When you think about things like public health emergencies, that is when we need the community to be able to mobilize. But if you have not invested the time, effort, and built trust, then when those emergencies occur, now you're trying to get them engaged, right? So we need to do that part where we focus our energies first on inclusion broadly. We should not forget the historically marginalized populations that are served by small community-based organizations. Because again, when those relationships and trust have been developed, it can be leveraged in so many ways that overall increase what needs to happen towards good for communities. The second challenge I see is alignment. If we are only coming from the position of where we are, you know, I always say to my team, sometimes I think people are only thinking about where they get their paycheck, right? Is that we are missing the opportunity to have more broad shared goals. You know, I know lots has been said about the North Carolina example. I think what North Carolina has gotten right is to zoom out and think about all those connecting points that can move things forward, and to then align policy, intention, goals, and data around that. That is a repeatable process that we could all engage in to help us get there. So those are my two challenges: inclusion and, you know, kind of that alignment that's needed. So the opportunities I see to create these compelling, scalable, and sustainable, promising, right, over the next 10 years, if we align together, it's really what I've heard said in previous panels, and it's been said here too. It's the same thing. This is not rocket science. It does require intention, where we say, let's step off the curb together. And I don't think that that's that hard. You know, like just step. You know, it doesn't have to be perfect. We get caught up in making more excuses and admiring more problems than is necessary. When I get up every morning, I say to myself, what else can I do to create the change I want to see? So I don't think of myself as outside the change, but rather in the arena all the time, thinking about it and trying to bring other people along, right? And so I think, you know, the opportunity is to really imagine, and later there's going to be a question that I'll share an example of how I've done that, is to really imagine what is possible and say that you will tirelessly work towards that. Why? Because, and I prefer to talk about human beings versus beneficiaries, enrollees, and all of that, because I think it gives us distance. And so what we must say is that we are focused on the good, the things that we are capable of doing for the human beings being served. And so all the tools around health information exchanges that can be great public utilities. It helps to improve where data is stored so that providers can create a better experience. It helps patients, members to have a better experience. You know, the tools are there. CMS, CMMI, I mean, like constantly putting out more guidance about these tools. And so it's a matter of us as leaders deciding that we will take a step to learn, grow, and do it over and over again. And then on an alternative payment model perspective, again, we've got tools. They are promising. The more we test and learn, the more we can leverage them. Things like social risk adjustment, so that we help to lift up those providers and invest in them to have the flexibility to do the best job in serving populations that are high social risk and medical risk.
Well, I appreciate all of your opening comments, and Karen, I'm not sure exactly what example you want to bring up, but I do want to do one follow-up right now on your comments and go to Fred and Georges on the same topic. First of all, your lived experience, which I know a bit about, since the audience probably doesn't know, but you've been helping teach some of the Duke-Margolis students and programs about these kinds of issues and how to build, I'm using your words now, a business model, a sustainable business model for these steps. So your own background included work with, and we talked about integrating public health and healthcare, but your own work has included a lot of work with community-based organizations in the DC area. and actually trying to create models for stepping off the curb together, which is not done just as a leap of faith, but backed by some kind of careful, thoughtful financial analysis, sustainability analysis. Can you talk a little bit more about how to move that forward in this space? That's been a recurrent theme today. There's a lot of ideas out there. We agree on the big concepts, but man, implementation is challenging.
You know, I don't like that word challenging. You know that already.
I know you don't, so you need to use it.
Stuck there. Once they use that label, I think they can't get past it. So the example I wanted to share is around medical respite. For those of you who don't know what that is, it's best not to just define it, but rather to give you an example. So if I have one of my enrollees at the hospital and they are ready for discharge, however, prior to hospitalization, they were experiencing homelessness and there isn't a home for them to go to, then if they, for example, have come in and they've had uncontrolled diabetes and they just had a toe amputated, they may not need to go to skilled nursing facility, but if they don't have a physical structure in which they are safely housed, they would be going back to the streets, and that would cause them more harm and another readmission. When oftentimes that happens when they get readmitted, they are now in worse condition. So that is not good for the healthcare delivery system, and it's certainly not good for that human being. So about 5 years ago, again, I literally get up every day thinking what else needs to be done. As we looked at data on our readmissions and those members that we had that had higher total costs of care, they were often experiencing homelessness. And this isn't new, right? The research tells us this. And they had very complex medical conditions that kept worsening each time. We looked at a whole host of other things that we could have chosen to address. I thought it was most important to address this one because it was certainly a big hole in our care delivery system here in the district. And so rather than focus on something that has a fair amount of solutions around it, I thought this is where we could really make a difference. I was reading something that Duke-Margolis said before, so I'll frame how we went about it in this way. He said that for Medicaid innovation, there are 3 key drivers. One is care delivery, the second is funding, and the third is capability building, right? And so this example really fits that. So in terms of care delivery, this big gap in the system where people aren't getting what they need at the right place because we had so few respite beds in our city. And when I further looked at the data, it was very specific that I had a lot of males being readmitted. Though we're a Medicaid program, the district chose some time ago to focus on adding childless adults, which in the district turned out to often be male. So we looked at the care delivery system, where we had what, and said, this is where we can make a contribution. In terms of funding, I chose to fund all the work to construct this medical respite idea. So it took us really almost 2 years in order to do that. It was well worth the investment because we created a structure that had phase 1 of a program, which is all around the medical stabilization, phase 2, which is the socially responsible component or responsive component that helps someone get to the point of being stably housed, most often in supportive housing. So now we have this robust solution. We needed the right partners. We created the model for how we will select and vet partners. So we have a housing partner, a medical partner. We have a partner that kind of does the overseeing and the staffing of the homes. And we have a health plan. So for the first almost 2 years, we funded and paid for all the beds. And so we had exclusive use of it as we made the investment work, And then after that, a social impact bond was done that helps the program to remain sustainable. And then, what from a funding perspective is really important is though I made that upfront investment, we can quantify specifically the dollar value of the return on investment. 40% of the persons that have been through, and we've had about 100 males go through the program, did not have readmissions, right? Did not have avoidable hospitalizations or low acuity emergency room visits. And so it has worked so that the ROI has been about 19% consistently. And then the capability building, wow, when I think about our partners and what they now understand about our pay for performance measures, they understand stuff about HEDIS. I mean, you know, they now have this, we're in this curve where it's now sustainable and scalable. And finally, I'm really pleased to tell you that we have now opened a home for women. We just opened it 2 weeks ago. Yesterday I checked, we have a census of 2, but we're going to get there. And the hospitals are very pleased to have this partnership and engagement as well. And so these are things that you can do, right? It is not insurmountable. We chose to step off the curb. We chose to fund it. And now we have an opportunity to celebrate the impact we're having in the community for men and women.
Well, congratulations on the new step. I'd not heard about that yet, but as you step out further, Brad, let's go from Washington, D.C. to Dallas, Texas. So you all have taken some steps. You mentioned some during COVID, but that built on a bit of a foundation. More steps since then. There are a lot of people without insurance in Texas. You're a very important part of the Dallas and Dallas-Fort Worth area safety net. How's your experience going on these key issues of envisioning feasible care models that bring together healthcare, public health, community resources, making them financially sustainable, building out the capabilities?
You know, we're a bit of an oddball in terms of this because we talk about the need for flexibility and funding, and we've tons of funding flexibility. You know, half our patients are uninsured. And it's incredibly liberating from a financial modeling perspective, because a third of our budget comes straight from the county, but another third is Medicaid supplemental funds. Those aren't, so 2/3 of your budget is pretty much, it's not dependent upon the encounter, you know? And so you can look at the problem and say, how do we design what the solutions are for that problem? So the respite example is a great example. We have people that are homeless who you couldn't discharge. So we talked to the Salvation Army down the street and said, you know, the shelters typically send people home during the day. They clear out during the day, they can come in at night. Well, someone with a toe amputation that needs to be there can't clear out during the day. And so we were happy to pay for some beds at the Salvation Army, stay open, keep a census there that would support that. They're happy to do it. It's not a hard negotiation. You know, because we're happy to support them. And so you can build programs like that. So, you know, big point, I think we get caught in trying to match the funding with the programs you want. And that's a natural part of all of our business, but there's more capacity there than people realize on the plan side, on the provider side. And so, you know, if I think of, you mentioned opioid use disorder and how we've been able to put funds together for something like that, taking county funds, Medicaid waiver, disproportionate share funding, ARPA funds, and now you've got opioid settlement funds that are going to be coming to the mix to build programs, because opioid is not a thing that's really responsive to fee for service, right? There's too much involved there. And so using those funds, you can build things like a neonatal abstinence syndrome program, so that pregnant women now get screened and treated. And then you combine that with, and we have a racial equity postpartum grant from HHS. So we can provide extended care for those people. You get control while they're pregnant and then keep them in care for a prolonged period of time, and not for just 2 months after the Medicaid runs out in Texas right now. Actually, that just changed last month to a year. So, but you know, you can put programs like that together. MAT, treatment for inpatient
Medication-assisted therapy.
Medication-assisted therapy for inpatients and for people coming through the ED, and for people we have in the jail, so that if you get them on therapy before discharge, then connect them to primary care. So a number of states are seeking Medicaid waivers right now to take care of people in jail, to ease that transition out of jail.
And create that capacity to deliver the primary care
Absolutely.
medication.
Get them started in jail and then connect them to primary care upon discharge. So you can control things a bit in that setting. In jail, you know, that's I'm going to say a captive audience, but I mean, it's not a great term, but you know, you've got them there, you can manage their conditions better, but then you lose at discharge. And so to be able to maintain that continuity. And so you know, that's not Medicaid in Texas because those people are not on Medicaid, they're uninsured, but we've got another different set of flexible funds. So I think the point is, you know, there are a lot of programs and there's a lot of flexibility already. There's not a lot of consistency across states, across entities, so that how to apply that. But big health plans, big health systems, there is capacity there to lean into these bigger public health problems. And probably a key to doing that is, you know, getting a little bit more clear about what those expectations are, the accountabilities. What does community benefit really mean? What do we expect out of your community health needs assessment and your implementation plans, those types of things?
Well, I want to get to next steps on making these examples more systematic, but first, Georges, we heard from Mandy earlier about the importance of federal, state, and local public health and perhaps helping to bring communities together around these goals and providing, supporting data to make that happen. It requires the kinds of upgrades and data infrastructure that Mandy was talking about. And since public health can't do it alone, you know, given the limited resources and data capabilities, some fresh thinking in how to bring these teams together. So what are you seeing as opportunities, you know, given all the challenges public health is facing now? And you mentioned this in your comments, lots of reports out there about what should be done, but hoping to use your comments as a transition to, okay, how do we make these kinds of steps more systematic and routine, the rule, not the exception?
Yeah, if I was a genie from Aladdin, I would take my first wish, and it would be to create, take the leadership to actually once and for all build a health information highway. Everything starts with that. I mean, public health is absolutely data-driven, has always been data-driven. The healthcare delivery system, at least on the financial side, has always been data-driven. Increasingly is becoming more and more data-driven. It's always been in many ways data-driven for the individual, but not necessarily for populations. And while we have been sticking our toe in the water, and by the way, we've had lots of progress in building health systems. The truth of the matter is that in many places, we still can't move an EKG across the street in a meaningful way, in a timely way. We're still debating about who owns the data. Interestingly enough, we don't do that with rideshare. We don't do it with food delivery systems. Increasingly, there are pockets of the health system that we haven't done that with. But if you go back and look back at the 50s, right, President Eisenhower decided we needed to, and others, for a variety of reasons, we needed to have a national highway system. They passed the legislation, they funded it, there was political will to build it. We had a patchwork of roads around this country. You couldn't get from one side of the country to the other, except for maybe Route 66 in a meaningful way, quickly. And they did that for national security reasons, right? There was a lot of concern. Those of us in my generation remember hiding under our desks, worried about the nuclear bombs we were going to hit. So as part of that mindset, we wanted to be able to rapidly evacuate cities. Not quite sure you could actually do that, but we just said we could. And they basically built the system. They incentivized, they got the incentives right for locals to loop roads together. And in some ways, they figured out this, the federalized system that we have to address it. And we have a national highway system today, which they continue to improve upon. If you look at many of the projects that we have in health information technology, we still haven't agreed on common data systems. We still haven't made those systems interoperable. We don't need we're probably never going to design a single medical record system, but we don't do that for anything else. We just made those systems interoperable. We've empowered the consumer, patients, the individuals, those humans to actually be engaged as part of the process. We made it easy for them to do, so that in this town, no matter where you are, you can get a car to pick you up and move you across town and get back in that town. And we need to do that with health systems, and we need to do that in a transparent manner. So that's the first thing. My second wish would be that we begin to get the health systems to compete on health more broadly, and not necessarily, I mean, we do amazing things. I mean, I remember as a medical resident, the terrible things we did for women trying to take care of their breast cancer. You know, I would get up as an internal medicine resident in the middle of the night and have to chase fevers, and you know, we would drop people's white counts to 0, and the terrible things we did. Now, what we do is we check your genetic structure, and then we target a medication. They don't get as sick, but they can, but not as sick. And we really have gotten amazing targeted therapy. The surgeries that we do robotically, Senator Tillis pointed out the wonders of using telemedicine now. The point is that we have built a system that is very much focused on the individual for excellence and outcomes for that individual, but we still haven't focused our efforts on excellence and outcomes for the health of a broad population. One story. When I was the deputy health officer for the state of Maryland, I ran 80% of the agency, all the public health programs. And my common experience was going to a budget hearing. It'd be me, my budget director, the legislator and his staffer who had to be there, and someone who couldn't find any place else to eat their lunch. And the room was basically vacant. When I became secretary and I ran the Medicaid program, I had to fight to get in the room because of all the money that was on the table that people wanted to fight over.
Yeah.
I would have loved to have more people there supporting my budget as a public health officer, the tobacco hearing, the zoning hearing when we were trying to reduce liquor store density. If we could get the healthcare community to be more engaged in changing the social environment in which we live, they would save themselves a lot of money. That $4 trillion that we spend on healthcare could be spent a whole lot more efficiently if we could get them more involved in actually thinking about how to engage the health of the community. And by the way, the evidence for that stuff working is there. It's just as strong as the basic science for all the other fancy stuff we do.
So let's talk about how to make those steps more systematic. And Fred, wanted to come to you because you know, I alluded earlier to a recent, earlier this year, Duke-Margolis National Academy of Medicine report on short-term steps to get towards these long-term goals, including things like aligning data standards and supporting data interoperability across healthcare and public health on key opportunities for increasing community awareness and enabling targeted action and accountability. It included recommendations along the lines that John discussed for shifting payments to healthcare providers, including in Medicaid, Georgia, to your point, to support accountability, making progress on those goals, maybe help support the kinds of stepping off the curb that Karen's doing. And it included steps to build platforms and support platforms for integrating community-based organizations and bring their perspectives and as Karen mentioned, that the lived experiences of people in affected communities into these community-based efforts. It's interesting to hear Mandy talk about New England Journal paper just out that lays out some next steps that CDC is taking in that direction to support data interoperability. John Blum, part of the CMS hospital announcements, you know, hospitals don't usually like to see new CMS regs, other things equal, but if there is a clear case, as he said, you know, this is meant to get to data standards that will reduce the burden of the healthcare providers on reporting to the different state and local public health authorities will give them data back to help inform their community responses. That may be a more sustainable path forward. From your involvement in that work and what you've been doing, anything you'd like to add on how we can accelerate this progress from where we are now, where there are these examples, but as George just pointed out, where it's not yet systematic.
Yeah, I think the comments Mandy made were just, we're reflective of the work that we've been doing in that space on kind of short-term things. What's the planning? How do you plan together, the health systems and the public health entities? And, there's some trepidation on both sides there, right? The health systems are huge. Public health is less resource, so they'll fear, getting taken over by the health systems. But I think you have to sit down and plan together. I mentioned, we're really supposed to do community health needs assessments, and that's supposed to involve these public health.
Well, yours does involve some
We sit
community
down with the public
perspectives.
health agency and we do it together. Not many places do it together. We present it to the public, and we present an implementation plan to the public. So trying to establish those accountabilities, or at least how you can work with each other to do that is an important first step. Pulling in the community organizations, these community hubs where you pull in and leverage the resources in the community, not just to kind of screen and refer, but then how do you also support the community-based organizations that are oftentimes much less resourced in the big health systems? And so that's a big piece. The data, that's a critical piece to everybody's discussion of what's the short-term impact. And certainly appreciate what those guys were talking about. Electronic reporting, doing it with national standards in the way that it's easy for health systems. So using Epic to, submit reportable conditions. I think on that AIMS platform now, where you can submit into that, we're submitting over 100 conditions, I think now. And then the local public health entity can pull that down, make it available to the community. You combine that with CDC data to create community dashboards. And then you can look and see, and combine that with real-time data, hospital ED visits, admissions, positive testing, things like that, to build a dashboard and to be able to see where are the disparities in the community, where do you need to focus resources and in real time in the community. So those are things that actually, happened during COVID, are happening to a less extent today, but can happen today as sort of early first steps. And then you talked about some of the payment reform and alternative payment models that would incentivize things like prevention, incentivize things like test and treat, so that you can move beyond, your silos to look at more of the population approach to things. So those are a few examples.
It's true that overall there is a lot of funding out there, and Georgia, sorry about your empty room, the public health hearings, but yeah, they are full on the healthcare side. And a lot of healthcare, community needs assessments, a lot of public health requirements to get CDC funding to produce some kind of plan for community health. But with the fragmentation of the funding, it's to George's point, it's kind of hard to get to systematic impact. So come back to you, Karen, since you are keeping on telling us, step off the curb, do this. How do we make these little pieces, all of which seem to be aiming for the same thing, more data informed, more meaningful, more accountable, and lined up with resources?
Leadership matters. Leadership matters. And sometimes when we are admiring the problem, we're forgetting to look in the mirror and say we have the capacity to lead. So I am always up for having a conversation and sharing my big idea, because I believe it is possible. So I love this vision of what we might accomplish together in a decade, because it is all possible. Is it quick? I mean, I was irritated as all get out that it took us almost 2 years to get through all the things. But I didn't lose sight of that. When I spoke at the opening of the women's site, I said, I believe dreams do come true, right? And I reminded them that there was a third part to my dream. So I like the wishes, because women with children will not leave their children to go to get the care they need, even if they're experiencing homelessness. They would rather live in a car with their child, do whatever is needed, but they are not willing to leave their children, which leaves them in a really difficult position. And so I want and plan to ensure, I told my team 2 years from now, that we will have a site for women experiencing homelessness who need medical respite that can be there with their children. And it will happen, because if you know me, it will.
And knowing you, there will
Right,
be
yeah.
a data collection and
Yes, right,
evaluation along with
but
it to
and
show
here's
the
thing, though,
ROI.
because we've shown the ROI. Guess what? For the women's piece, philanthropy chipped in, right? So I think we have
So
to be.
another kind of alignment
Yes,
of funding,
right.
yeah.
So we need to be steadfast in what good, great, what's possible looks like, and have those conversations. I mean, it was a lot of conversations in 2 years. I say patience is a virtue. It's not one of mine, because I have a sense of urgency about what can be done for people who are suffering, not because they want to suffer, because those of us with power, influence, and capacity to make something different happen are failing them. And so I know we can do these things. It takes a lot of work and conversations. When we were vetting partners, it took a really long time, because we had to, even though I liked many of these people, I'd known them for 2 decades, they weren't the right partner. But that's the work. I think when you come into this space of healthcare delivery, we must come into it with a very strong commitment. We don't give up. We are working for something and for human beings, and just don't give up. And so I have conversations and I wear people out. Our previous health head of our Department of Health, she would say, Karen, what are you doing now? Because I'm talking to her staff, but it is work, and it is the right work. It's the good work. It's good trouble to make this happen.
We have a few minutes, so I've been trying to keep track of questions, comments coming in and cover those here. We have a few minutes for questions from people in the room. So if there are any questions you'd like to ask or make, I see one hand up in the back here. And please wait for the microphone so everybody online can hear you.
Thank you for.
And please let us know who you are when you're.
My name is Fortune Shamovi. I'm a Congressional Health Policy Fellow from the Congressional Black Caucus. My question is, when it comes to the representation of public health in a congressional setting, how alarming is it that a lot of them are leaving, or a lot of them aren't even applying for roles in Congress? So I do believe that when it comes to public health, we're losing sight of that, since especially with COVID and how that came to be. How alarming is that to you guys that we don't have a lot of representation?
And just to be clear, talking about public health staff positions supporting
exactly.
Congress. Yeah.
That and just in a general sense of focus of public, whether if it's funding or whether if it's other priorities that are just hitting the back burner.
Yeah. I know, Georges, do you want to?
Yeah, so I was a big concern. I think one of the challenges we have is people often don't understand what public health is. I mean, there's a lot of interest in public health. It's one of the most rapidly growing areas of academic study, and people are going to school. It's not that we don't have people interested in public health. The challenge is getting them to go into the right field. So I do a couple of things. Number one, I tell people, my colleagues, that public health is by its very nature political, and don't be afraid of it, but you can't be partisan. Political, but not partisan. Secondly, it's challenging. There's lots of interesting stuff you get to do every day. One of the opportunities you do have, if you really want to serious about learning about policy, is go work on the Hill, or work in a governmental health department. Third thing I tell them is that in most of the times you go into governmental public health, at least, you're in charge. So if you're in charge, be in charge. And you ought to see yourself as a chief health strategist for the communities in which you're responsible for. And just remind you that the health official in those communities is the only person in the community with the legal responsibility for the health of the community. Everybody else can run away. Everybody else can find an excuse not to do it. Health official cannot. And so I encourage them to understand that's part of the role.
We're almost out of time. I just wanted to build on this very quickly because this is something that we think about a lot from a standpoint of being an educational institution that's trying to train and support future public health leaders. We don't actually have a public health school at Duke. We collaborate with our friends, as long as it's not basketball, at UNC and Billings, great public health school and great joint programs going on. But what we've found is a lot of our students with business, you're getting an MBA or getting an MD or nursing or public policy degree actually have public or population health interests and
Yeah.
very engaged. Karen, you've taught some of them along the way. What does the future training and background for future public health leaders look like? Ask you all, because I mean, you're doing public health, but you're not, I don't think you're officially counted as
It includes all those
public health.
degrees.
Yeah,
but
yeah.
Fred, you've had a great experience with this.
Yeah.
Yeah, well, like you said, you see it sort of weaved into everything that you're
We're
doing.
trying.
We see our physicians that, or that have these interests. We don't, and they don't necessarily call it public health too, but they want to do health policy. They want to solve the uninsured problem. They want to do health equity. But they may not necessarily articulate it as public health, but there's a lot of interest in that and what the application might be within health systems.
Mm-hmm.
I love.
You're a public health person.
I love that. Well, since you named other schools too, but Georgetown University, when they started their program that has a component that allows any other students outside of health to also participate and take classes. So they have this immersive component where they bring the students to a community site. So I was selected and I was so honored. But I was so amazed. I mean, you had engineers. I mean, there were so many people outside health. I think that is something we can leverage, and we should, because health in all policy, equity in all policy requires the people who are going to think about what that lived environment is going to look like, the people who are designing the streets and the spaces, and right. And so I believe that's something we should be growing more of, giving more thought to, and figuring out how do we lift up more people in historically marginalized communities to be part of getting that education.
Yeah.
Because it's going to take everyone to create this more sustainable, scalable, equitable system. And academia is a great place to do that.
I completely agree with you. I know the question was phrased in terms of a big challenge. Sorry about that word, Karen. I know you don't like it, but I gotta say the students that we're seeing these days, we may live in silos and fragmented funding. They don't.
They don't.
And they see the connections between them. And looking ahead to the next decade, I think if we can build on these educational programs, the next generation is going to get a lot further than we have so far. But we are making progress. And so I went in on a bit of optimism. We are going to take a break now. Thanks for staying with us to this point. We'll be back at 2:30 with another big picture view of where we've been, where we are, and where we are going in value-based healthcare that I'm going to come back to a lot of the themes that you all have been talking about. Thanks so much for being with us today.
Welcome back to the stage, Mark McClellan.
I didn't want to impede on the voice of God there, but I would like to welcome you all back as well to the session on aligning incentives and infrastructure for the next era of value-based care. And I can't think of any people better suited to take a step back with me to discuss where we are and where we're going and where we want to be in terms of value-based care than two longtime colleagues and healthcare leaders joining us today. I gotta say, one of my special privileges in my career is getting to work in administrations with both of them. So Nancy Ann DeParle currently is a managing partner and co-founder of Consonance Capital Partners and a healthcare leader in multiple Democratic administrations. Alex Azar, who I hope is about to come on the screen, is now with Seraphim Strategies in the University of Miami, where he's joining us from today, where he is doing some teaching. Also a healthcare leader in multiple Republican administrations. And in this session on Next Era, there you are, Alex. Good to see you. Just introducing the session. So when we're talking about Next Era, well, I don't want to imply that it's been a bumpy, I don't want to imply that it hasn't been a bumpy road, but there has been significant growth. If you look at the numbers in value-based payment and value-based care, I think it reflects a long-standing bipartisan support for these efforts, both of you going back even before it's called value-based care. I think in the Clinton administration, certainly through the Obama administration, the Affordable Care Act, and CMMI and those steps are important. Alex set a goal at HHS when he was HHS secretary in the Trump administration, which the Biden administration has actually reinforced, of getting 100% of Medicare beneficiaries having access to such person-centered, accountable care, not fee-for-service based payment and fragmented care. And actually today, again, if you look at on paper, we're at a point where most Medicare beneficiaries are either in Medicare Advantage plans, which have accountability for total costs and some measures of quality, or in so-called Medicare shared savings plans or related accountable care provider arrangements in traditional Medicare, which are also paid significantly on the basis of people and their total costs and outcomes. As we heard earlier, those goals connect to public health and social service, social needs goals as well. So collectively, the two people with me today have been closely involved in many of the key policy steps to get from the theory of value-based care to where we are today, where there's actually a lot of discussion, Nancy Ann and Alex, about what maybe inflection points, coordinated person-based arrangements now include most Medicare beneficiaries, a growing share of Medicaid beneficiaries, even growth in commercial plans. On the other hand, if you look at the pace of growth in these programs, it's not on track to get to the 100% by 2030 goals that CMS in both the Biden and Trump administration have set. And while there's some very promising examples of success, and we've talked about a lot of them, I think most Americans probably wouldn't agree that we're there yet in terms of coordinated, convenient, affordable, person-centered care. And we also talked earlier today about clinicians still feeling a lot of administrative burden, not just because of fee-for-service claims and fee-for-service prior auth and things like that, but encounter data reporting, other administrative challenges in capitated health plans. So I'd like to talk with you all about the big picture here. Where have we been? Where are we now? And what do we need to do next in terms of achieving the vision of value-based care that's centered on people, that's achieving what Senator Tillis started out by saying, measurably better outcomes, lower costs, and better quality of care. What's been a main reason for progress? Where are there areas of concerns? Don't feel like you have to answer all these questions in your opening comments, but I would like to get a lively discussion going. And Nancy Ann, maybe I'll start with you.
Great. Well, I would start with the secretary, but since I'm here in person, Alex, I'll go first. I do think that sometimes we focus so much on where we need to be that we forget how far we've come. And I've run into some former colleagues here at this event, and we've been really marveling over how far we've come. We still have a long way to go, don't get me wrong, but when we were working on the Medicare Plus Choice program back in the late 90s, it was a revelation to have hierarchical coding.
Yeah, the HCC.
Coding, the HCC.
Yeah.
We were moving from sex and age, basically, as the two things we were using to risk adjust. So, you could, and you are, I think, and you and your colleagues at Duke-Margolis are arguing now that we need to move much faster to something else. And that's been a long time ago, and you would hope we'd have a better system of risk adjustment by now that would be even more informed by other things, and we should. But still, to go from where we were with the Medicare, then called the Medicare Risk Program, the Medicare HMO program, to where we are now with Medicare Advantage, with as many beneficiaries enrolled, with the kinds of quality and star ratings they have. And yes, a lot of things need to be fixed about it, but that's very positive. With ACOs, I have a vivid recollection of sitting there in my office in the White House, and we're working on the policy on that. And it might have been John Blum, actually. He's gone back to his desk for the afternoon, just saying, well, what do you view as success with these ACOs?
And I said, I don't know, 20 or 30 of them, maybe. I wasn't even going, Alex, for one per state. You know, I didn't know what would happen. It was in both cases, it was a little bit of, you know, if we build it, will they come? And they have. And, you know, the shared savings program, I think had, well, all 11 million beneficiaries, I think, in those programs and ACO programs, and saved something like $6 billion over the last 5 years. And if you look at each one of them individually, there's 50 programs, I think, that the CMMI ran. Not all of them have saved money, but taken together, they have amounted to something that, you know, CBO at least says, you know, something's happening here. What it is isn't exactly clear. So there's a few people in here who know that song. And it is. It's changed behavior. It's changed the way people practice medicine. And that's the lever. And I want to compliment Alex because he came in, he looked hard at it, he continued the progress, he set forward some ambitious goals, all while he was coming up with a vaccine for all of us for COVID, which I appreciate. So I think, you know, the sky's the limit. I think we are going to continue moving forward. I think it's amazing what we've done in the last 10 years. And I think, I don't know who's keeping score, but CBO did come back a year ago and say that they overestimated by $1 trillion how much Medicare, Medicaid, and the Affordable Care Act subsidies would cost over the last 10 years.
Yeah.
So if they're the scorekeeper, maybe they're just not looking at the trend closely enough.
Yeah, although CBO did, just to get a little technical here, so they were just looking within those pilots themselves, not beyond the evaluation window, not broader, et cetera. Well, Alex, your perspectives to start this off?
Yeah, just want to make sure you can hear me okay?
Yes.
Yes.
Great. Well, first, it's a real honor to be with Nancy Ann and with Mark here, the two of the great leaders in the transition to value-based care. And I appreciate the chance to participate from the U. I am doing my week of teaching down here, literally spent the morning teaching value-based care in the business school to our MBAs. I would echo what Nancy Ann has to say, which is I get very frustrated by a lot of the naysaying out there about the slow pace of progress. When I look at the fact that 15 years before I was secretary, we converted over from M+C to Medicare Advantage. I could not have imagined, first, that I'd be secretary, but secondly, that 15 years later, the majority of Medicare beneficiaries would have chosen to be in an MA plan, that MA would be a sustainable, robust business model with the government as a predictable business partner, delivering better health outcomes, delivering coordinated care for people. That's an amazing and huge accomplishment. But then when we add on top of that, how MA functions by passing risk down to provider groups, the deep penetration, especially here in Florida, of value-based practice arrangements within MA, and then the work that we have, even managed Medicaid. Managed Medicaid itself has elements that you could call value-based, but I'm involved in entities that are doing capitated payment risk for managed Medicaid plans in a value-based, holistic, social determinants of health way of delivering care. I'm involved in a kidney care company that is delivering through the kidney care demonstration models of capitated payments, value-based care and delivering real outcomes. I'm seeing this on a daily basis in healthcare. And yes, there are pockets where it's not happening. There are pockets of fee-for-service resistance. There are challenges in rural America, absolutely. But when I think of the journey that we've been on, that's been a totally bipartisan journey, I say, yes, it's taken a long time because we've had to learn to walk before we could run. I mean, look back 2005, 2006, we were trying to figure out how do you bundle? What does a hip replacement even mean in the system? We were paying for reporting just to get basic quality information to figure out that. We were then moving to ACOs, and our mentality was paying for outcomes, which was a noble ambition, but I think we found that was actually quite subjective and very hard to do and imposed incredible administrative burden. So we've now transitioned a lot of our thinking to basically delegating and rewarding total cost of care management with aligned incentives, placing the risk at the provider and patient level. Is it fully there? No, we're still learning. ACO Reach is still a work in progress. All the demos works in progress, but we're talking about changing how we practice medicine in 1/7 of the American economy. That's going to take time. But as Nancy Ann said, we should be celebrating the incredible progress and the fact that, what do we know? We know that value-based care works. So we don't have a question of, does it work? Does it deliver better outcomes? Is it more efficient? The question is, can we actually get there? Can we build the muscle memory, change the behaviors, how we do all of this? That's a level 1 kind of problem. So, we at least know where we're going.
It does seem like the direction is going to continue. So there have been a number of surveys of healthcare payers, public and private, that generally go along with the CMS goals of, yeah, we're pushing in this direction through Republican, Democratic administrations. What we heard earlier today in this conference was notable, I think, that from the public health side, at CDC, in the public health community, they don't see a path to getting to real support for population health, which is a team sport, to quote Mandy Cohen and her team, without this kind of alignment on accountability and supporting steps for population health. And we heard on our last panel about community-based organizations have an important role to play, but also difficult to be accountable, sustainable without this kind of integration. So Alex, let's move on to your point about, well, okay, if this is the direction we're going, couldn't it be faster and easier? I appreciate the optimism, but I think for many healthcare frontline providers today and organizations trying to make this shift are reluctant to do so with, one foot in each canoe or whatever analogy you want to make. It still seems challenging. And the theme I'd like to start with on this, and maybe go through a few, but Nancy Ann, you brought up the data systems that we're using today to support Medicare Advantage and these accountable care programs. And data infrastructure was a key theme throughout. It's gotten better. There's through electronic record standards and TEFCA and FHIR and all these words that Anish is going to explain later. There is a lot more interoperability and ability to use much richer, more clinically accurate data. Same data that's being used for clinical care decisions in real time as opposed to claims. And you mentioned, when we started out these payment models, people think about them as being population-based and accountable for total cost. They do depend fundamentally today on two things: risk adjustments and the link to measurable aspects of outcomes or patient experience or quality. When we set up, and you were involved in this with Medicare Plus Choice and the HCCs, and then I inherited that when we started the Medicare Modernization Act with Alex, very closely involved too. We asked at the time, well, what's the best data we have on individual patient risk and their associated resource use? And of course, the answer in 2000 or 2004 was insurance claims data. And if you had told me then that in 2024, we'd be on version 28 of essentially a claims, not only claims, but fee-for-service claims-based system where for these organizations that have moved out of fee-for-service and into accountable primary care practices that are being paid on the person level, or as Alex said, specialty practices that are focusing on delivering short or long-term episodes of care effectively, that not only would there still be fee-for-service basis for the payment system, but these organizations would be required to report so-called encounter data to make it that looks like fee-for-service care, even though many of them are using team-based care, people who aren't compensated, community health workers, others who get little or no payment under fee-for-service, care coordination supports, digital tools, AI-enabled care. Yeah, that would shift care from being more labor, at least expensive labor, to more technical support, tech-based care, personalized care. We still have the same data underlying our system and reinforcing, actually putting more burdens on healthcare providers in accountable systems to make it look like fee-for-service. Wouldn't have believed it. Yet here we are in version 28. It is hard to change infrastructure, but that is a theme that's come up a lot today. Duke-Margolis has been doing work, as was alluded to earlier, with a range of organizations. People have different views about the future of Medicare Advantage and ACOs, but agree that we got to modernize our infrastructure. I appreciate thoughts from you all about how we get to, and data is an example, maybe there are others, but how do we get to an infrastructure for the future of value-based care, where this is the predominant system, not fee-for-service anymore, that's more reflective of what data and infrastructure for better care, for addressing social drivers, for involving community health organizations, what that should look like for the next 10 years, since we've got a longer term focus today.
Well, you had me at hello on that, because I agree that I would not have thought that 20 years later, we'd be still building on the same chassis, if you will. We've talked in our preparation for this session about, is value-based care now the chassis as opposed to being a hood ornament? And I believe it is. I think Alex believes it is as well. But the payment system still has the old, more than 20-year-old chassis, and how do we move to a new one? And I'm not just tweaking Alex here, but I really think we need something like an Operation Warp Speed, where you'd sit down with the industry, though, because they're very important players in this. If you're talking specifically about Medicare Advantage, for example, you know, how do we design something that is implementable in a reasonable time frame, that is good enough to move us to the next stage of this? Not perfect, because that isn't, you know, nothing we design will be perfect, but that can bring everyone along, can be better for the beneficiaries, at least not disruptive to them as we're going to this new system. I suspect everyone at CMS, and certainly we can ask Mina, who will be here shortly, and the Center for Medicare, that they all agree that we need something like this. It's just, how do you get there? So I'd sit down with the industry. I'd get the experts from CMS in the room, you and your Duke-Margolis colleagues who spent a lot of time on this, and figure out a new way of doing it. That's what I would do.
Alex, any comments on this topic?
Yeah,
and then feel
yeah,
free to bring
yeah.
up others. Yeah.
No, absolutely, Mark. In fact, if I had, God forbid, had a second term, I was planning on leading a national convening like Nancy Ann just talked about, around a recognition of the fact that MA is now the tail, what is it? The tail wag the dog wagging the tail instead of the tail wagging the dog, and or vice versa, whatever. That as the majority player, we've relied on fee-for-service, whether for RA or for just benchmarking the premium structure. And that doesn't necessarily work when you're the dominant part of the equation. And how do we think about it for both purposes? I mean, you've raised the risk adjustment aspects. I think a lot about how do we come up with premium structure? You know, do we think about a competitive bidding type approach in the future? But, you know, we've got the tail wagging the dog at this point in many markets, fee for service being quite the minority feature and not representative of the patient sample that's in MA, distorting and just really could be distortive of the market. I would say on risk adjustment, though, that it's just very important that we remember why we do risk adjustment. It's not a give back to industry. It's not corporate welfare, et cetera. It is a mechanism to ensure that we do not get adverse selection or get plans pushing away unhealthy beneficiaries, but rather being willing to adopt them and bring them into these wonderful and very productive coordinated care models. So we just have to be careful that as we think about change, we don't throw the baby out with the bathwater. That I think really one of the tremendously good things about the stability of MA has been the risk adjustment infrastructure underneath it, that behind the scenes makes a lot of the financials work. So even as we tweak it, fundamentally adjust it, whatever, let's keep that in mind. It's not the enemy, it's actually a key enabler of the stability of the program.
The predictability, the reliability.
Yes, I agree. And I would also argue that using something like risk adjustment and fee for service could make that a better model, to the extent that you know, there are complaints about risk adjustment in Medicare Advantage, as Alex says, painting it as the enemy or somehow an untoward element. It isn't. It's supposed to help enable the proper provision of care to the right beneficiaries. And fee for service doesn't really have anything like that. And I would argue, you know, to the extent that that will remain in some markets, some people will continue to desire that. We should think about risk adjusting on the fee for service side.
And on the fee for service side, the claims data is notoriously incomplete in terms of diagnoses, and yet we now have on the fee for service side too good interoperable electronic records that could be more focused on this.
Exactly.
Yeah,
Well,
this is,
and Mark and Nancy Ann, that's where the more people we can get into what's now called ACO REACH on the fee-for-service side and other fee-for-service like capitated payment models, we need risk adjustment there that can actually drive that type of higher quality coding on on what remains of the fee-for-service side, because that will be instrumental in those risk adjustment models.
yeah.
It's
And
true.
I do want to talk about the other part of payment in value-based care. So it's accounting for patient risk, but it's also rewarding, supporting steps to not just deliver more services, but as we've heard about all day, identify health risks that are addressable and address them effectively and have accountability for that. Talking about things that haven't changed over the last couple of decades. Well, a lot of the STARS measures, they're important. I get Alex's point about predictability. They're kind of similar to what we saw back in, again, I have nothing against patient experience measures or claims-based, manually reported quality and outcome measures. But there too, it seems like progress is possible. And on that side, CMS actually has a so-called foundational strategy to move from reporting kind of the old-fashioned way, which can be burdensome on providers. And again, getting from here to there is a challenge, but with more automatic so-called API standards for pulling data relevant to patient risk out of the clinical records and having that be a direct basis for reporting on quality. It seems like there's a lot of overlap between the data needed for understanding performance and performance accountability and the data needed for understanding patient risk. One of the things that Rick Gilfillan, who has contributed to some of our ideas, I'm not claiming he agrees with me on everything, but contributed to some of our important contributions, our ideas in the space. That look, are there ways to maybe reframe how we're thinking about risk adjustment to not just be about risk of patients for the payment adjustment, important as that is, but also supporting maybe better accountability performance measures that clinicians could get behind. We have some good ones in the program now for primary care, but I think a lot of specialty care providers, patients with different kinds of needs are feeling a bit left out. But appreciate any comments on that part of the data infrastructure.
You want to go first, Alex?
I would just say briefly that it's important to remember that the various, whether it's STARS or some other replacement on quality measurement, is, I think, very important. It would be nice if it could be automated. It would be nice if we could remove a lot of the administrative burden and provider friction that comes from it. But I do think it's an important check in the system as we capitate payments, because we have to always have if we're doing total cost of care, say, we have to always have the check in the system to monitor, are we getting perverse incentives in the system to make sure that the providers aren't artificially keeping a patient out of the hospital or in any way you sort of fiddling with the system on total cost of care. Those types of metrics can be a check or an early warning system of inappropriate bad behavior. Hope it would never happen, but yes, if we can make it more streamlined, more efficient. I hear from providers all the time the burden of reporting. It would be great to automate.
Yeah, you're reminding me, sometime during the Trump administration, it was announced that CMS was going to be streamlining some of the quality measures, and the rulemaking was coming out, and I got my cup of coffee and my red pen out, and I was going to read the rule, and I assumed I would have a lot of beef with it. And what was disappointing to me wasn't the things that were being eliminated to reduce burden. I kind of agreed with. But it was that, gee, we still have these same measures, what you said at the beginning. I was really surprised we hadn't gone further yet on that. And that is an area where we definitely need to spend some time and come up with something that is more relevant. And as you say, probably is now being captured in a better way through the electronic systems that we have. So I would definitely say we need to do more there. Whether it's star ratings or something else, I agree with Alex. We need something to put out there, just like he put his goal of 100%. We need a goal out there that firms and providers will go after. And my experience has been that with doctors and with these, very professional managed care plans and the ACOs, they want to achieve that. If you tell them what you want to see, they will go after it.
And it's meaningful,
And
clinically meaningful.
Clinically, and there are incentives and they're properly paid for it,
financially
they will do it. So let's be clear about what we want, and then we should audit, obviously, to make sure that there's not, people aren't playing games with it, but That's what I think we should do.
This has been a great discussion. I could go on for a while. Maybe just one last comment. So we also talked today about the need for better evidence. You talked about some of the gaps or questions that still remain from CBO report, from pilots. CMMI has been a critical part of Medicare and CMS efforts, now Medicaid too, to generate better evidence and support it. Any quick thoughts about CMMI, about the CMS workforce and kind of ramping up better evidence to help accelerate progress?
I think they've done a magnificent job under both administrations, 3, I guess now, and they should just keep going. I like the sort of strategic look that they just took at themselves and setting forth a strategy going forward, having a little tighter focus. I think all of that makes sense. I think it's important not to view what they're doing solely through the lens of whether in a narrow sense you can show that it saved money, because I don't think that is what this is all about. I think it's about something bigger than that, but I think it's going to continue we'll continue to reap benefits from it.
Yeah, I'm a huge supporter of CMMI and its mission. In fact, every time I was secretary, I needed to talk about repealing and replacing the Affordable Care Act. I always had my fingers crossed behind me saying, but not CMMI. Of course, that's in there. It's a very critical part to how we need to reform. And as Nancy Ann said, we need to not be too critical where we have models and demonstrations, especially some of the earlier ones that maybe they didn't yield savings. Maybe they didn't actually yield great results. That's part of the learning process, and we have to be comfortable with that. And I'd have 2 cautions. One of them is for CMMI. As we go forward, don't be afraid to be bold. Don't be afraid to declare victory and say, we've learned enough and it's now time to generalize. We know, as Mike Levitt would say, we know where the northbound train is heading. Let's get on it and just do it sometimes. And then for my friends and colleagues, it would be, as sort of Nancy Ann was alluding to this, we're talking about massive behavioral transformation in the healthcare system. One thing I've learned through decades of leading very complex, big bureaucratic organizations is it is impossible to deliver transformative behavioral change when it's thought of as a zero-sum game of somebody has to win and somebody has to lose. And so we may need to be putting more money into the system. We may need to be incenting rather than penalizing to get the muscle memory, the new patterns of behavior. Remember, this is not easy to do. You're talking complex IT systems, patient segmentation identification, patient engagement models that have to change to really deliver value-based care. You're asking people to do something fundamentally different. And it's a lot easier to do that by incenting them rather than instilling fear in them or loss in them to do it.
Totally agree. And I've learned that over my years of working with Medicare and Medicaid as well. And Mark, you're the clinician here, but not only were we asking them to do all those things, but we're asking teams of people in hospitals and other groups of providers to work together when they've been in silos before. Yeah. That's the hardest thing. Yeah. And they're doing
new capabilities, need new support.
This whole idea that you can have a point estimate of how much that really costs, and if it goes above that, then that's a failure, is wrong. And I think we saw that during COVID. You need, my former OMB colleagues would cringe, but you need a little money sloshing around in the system to sort of make this stuff work. And you get people to believe they can do it, and then you can be a little more efficient with how they do it.
And then you keep the focus on getting to those results and having infrastructure that supports it.
But I'll pay more for better results, by the way.
Amen.
All right. We could go on for quite a while. I do want to have you guys back maybe in a few years so we can reassess how much further we've gone down this road.
Can we go to Miami?
But yeah, maybe next
come to Miami.
Duke-Margolis event down with Donna Shalala and Alex in Miami. So thank you both so much for joining us today. Really appreciate it.
Thank you.
All right, and now to follow up on this terrific discussion, I'd like to welcome Rob Saunders onto the stage. I think, Rob, you're going to introduce our next set of panelists too.
That's that one. Got it. All right, I'm calling folks onto the stage. We have 3 great speakers with us today. We have Meena Sheshmani, who directs the Center for Medicare at the Center for Medicare and Medicaid Innovation. Medicare and Medicaid Services. We have Will Schrank, who is a venture partner at A16 Bio, Health. And we have Anish Chopra, who's coming to us from Care Journey. So invite them all to join me on the stage. And it was great that we had the prior panel really to warm us up here a little bit. And so maybe I'll start with you, Mina, because there are however many millions of Americans who get their care through the Centers for Medicare.
65 million.
65 million. It's a lot of people. Can you talk about some of how you're taking value-based payment, which we talked about at a high level here, and really embedding that into the work that you're doing?
Yeah, absolutely. And it's great to be here with all of you. And I will echo a lot of what Nancy Ann and Alex were saying, that there has been a lot of progress. And there is, there are places that we still need to go. And we are really trying to do that through the Medicare program. And I think key to all of that is understanding everything that's going on, because you can put something in a 2,000-page regulation, post it on the Federal Register and declare victory and not really have anything change on the ground. And so it is venues like this that are so important to really continue to have that momentum. So, Alex in particular had mentioned that there are still, pockets and areas, challenges. And before I took this role, I was practicing as a physician and leading care transformation and leading value-based care models for a system, and also just traveling the country, speaking with, providers and patients about why things, how can we move things along further? And a few things that came up. Number one, the lack of alignment in quality metrics, lack of alignment between the different programs, the CMMI models, Medicare, right? That pilot graveyard, right? That I think all of us do not like to have. How do the different things actually line up to really drive momentum? A second, the Secretary Azar had mentioned, is muscle memory, where you are asking people to change the way that they provide care or navigate or interface with care, when physicians would say, well, I didn't learn any of this in my training. I didn't learn what a community health worker does and how do you contract with a community-based organization. And a third aspect is the infrastructure and what it needs to actually invest and then engage in these types of models. And again, when I was working in this space leading community health, how do you hire a community health worker or spend money to contract with a CBO with the hope that 2 years down the road, there's shared savings that can be applied toward that to make the budget work for the CFO of your organization? And so I think a lot of what we are doing really tries to address some of those challenges to, again, continue to garner momentum in value-based care. So in our overall care transformation, in our traditional Medicare program, starting from the physician fee schedule, we are taking lessons learned from innovation center models to really embed into the physician fee schedule itself. So you can start to drive accountable care at the very ground level in our payment structure. So for the first time, we are paying for community health services, paying for care navigation, paying for caregiver training, and also working with the Center for Clinical Standards and Quality to standardize and drive the quality metrics that go along with that. So that way you can start to address some of the cash flow issues. You can start to address some of the muscle memory. You can give providers the confidence to continue to move down the continuum. In accountable care organizations, Medicare Shared Savings Program obviously being the largest, we have really taken a lot of the feedback that we have heard of the current barriers to entry, barriers to retention, making changes to the benchmark, changes to the attribution, and importantly, again, taking lessons learned from innovation center models. There was the ACO investment model that had been done when I was in the Obama administration and then was sitting around and not scaled. So what did we do? We scaled it. We created the Advanced Investment Payments Program in the Medicare Shared Savings Program. So we are now giving upfront investment dollars to smaller providers in rural and underserved areas to become accountable care organizations. So again, using lessons learned to be able to grow the program and then aligning with the Innovation Center. So as they continue to test, doing so in a way that is streamlined and makes sense. The most recent example being PC Flex, which is being rolled out, which is being tested on the MSSP chassis. Again, because ultimately, what do we want? We want to be able to as a secretary had said, scale when something works. So what better way to do it than to actually test it in what you would then scale it in? You know, the value-based care concepts, I know everybody tends to think about ACOs and innovation center models, but I also think it's important to remember, as you know, Nancy and Alex had spoken about, that it also exists in Medicare Advantage, where, for example, getting better transparency on supplemental benefits, getting better data. You know, we're now requiring that supplemental benefits that plans demonstrate the health outcomes when they do their bid process. We actually have a request for information out right now to be able to get better data and information on the value-based care and accountable care relationships that exist in the Medicare Advantage space. And these concepts also play out in our implementation of the Inflation Reduction Act. When you look at the negotiation program that we stood up, the foundation of it is the benefit that a drug provides in the real world setting. We did 10 patient-focused listening sessions, in particular, to be able to hear from caregivers, from patients, from healthcare providers, of how these drugs are actually working in practice. And we all know that post-marketing evidence is a huge area for opportunity for us to understand, you know, how drugs actually work in the community setting to make sure that we are rewarding the kinds of innovations that people need and making sure we have access to those innovative treatments. So really, the value-based care agenda is across all of the Medicare program. And I think to echo what we heard from the last session, we all need to just grab on and move forward, because so much of behavior change is just kind of linking arms and taking that jump. And it's important to see the steps that we are putting in place, we at CMS are putting in place to enable that leap forward.
Thanks, Mina. And I think one of the things I'm taking from your presentation, as well as from the earlier panel, is moving from that hood ornament to more of the chassis, where we're seeing things done at scale. I'm going to have a question for Will and Anish, but before I do that, I do want to maybe throw up the Slido QR code one more time, just to say if folks do have questions they want to put in, here's how you can put that through, and then I'll be monitoring that from up here and make sure to pull that into the conversation. Another point, Mina, that you brought up was a point about infrastructure and how important infrastructure is to making all this work, especially if we're trying to do things at scale. And one of the points that got brought up was about data. So Anish, I'm going to pick on you.
Yeah.
You may have thought about data once or twice in your career. Talk to me about where you see data really fitting into driving value-based payment, and where do you think we need to go? Because I think the other thing we've heard here is that we're not quite where we want to be with where our data is. So
yeah,
where do you see things?
Thanks for the opportunity, and Mina, for your comments to set us up. Three important points for the group to understand. One, when we initiated the I was on the transition team, I guess, before the High Tech Act, the original Meaningful Use program was dreamed of as sort of the model to fund the infrastructure for the world we wanted, which was a more population-based, value-based world. And to be very frank, the message up front is that that first chapter was successful in driving adoption of technology, but it hadn't really pivoted towards serving the VBC as chassis versus hood ornament. And so what we got was a lot of continued digitization in pursuit of fee-for-service medicine. So we had this demand signal mismatch. The market wasn't asking for the VBC components in the software that they were buying. It was mostly continuing what was needed. So there was a little bit of a misalignment there on the demand signal. As a result, we kind of lost a step on taking advantage of some of the more real-time data signals to figure out if patients are struggling or have been poorly understood about their current disease state. The good news, and the reason point one is here, is that we've now caught up and are today on the other side of the curve. Potentially, and I'll say that because I get to my other 2 points, we are now in a position where the vast majority of electronic health record systems are certified and shipped, capable of providing the real-time information we need for value-based care. That's the point. We missed the first phase through the Cures Act. We got there as of December 2022. over 300 EHR vendors have now got the technical ability to produce a nice, clean summary of a patient's health condition in real time for patient access and value-based care access. Point one. Point two, we have had a little bit of shift on the payer side. So value-based care is really the blend of understanding the physician's records and understanding longitudinally what's happening to the patient, which is held by, say, payers like CMS. So you got to put those two pieces together. Here, the message is be like CMS. Most health plans still send 30 days old adjudicated claims to physicians to coordinate care, which basically means I learned about a care gap about a patient 8 weeks ago, and now I want to take action. It's a little bit delayed. With the ACO REACH model, CMMI has now offered a partially adjudicated API, which is updated every single day. This capability, value-based care networks are saying, closes an important gap where they wouldn't know if a patient's been admitted to a hospital. Maybe 4 out of 10 times they can kind of buy that data through the third party in the market. Now they can actually see it, usually within a kind of week or two of the visit or the encounter happening, because it shows up in the daily feed. CMS has also regulated all the MA plans and other plans to follow suit with this daily feed, but the delay is it's 2027. So CMS has actually gone live now. The rest of the industry is a bit behind, but that's my third point, Rob. And this is the point where we can have nice things. We can have nice things. The National Coordinator for Health IT has launched a nationwide interoperability network so we can realize the benefits of all of this investment. And what we've got right now, for the first time ever, is a common agreement amongst the EHR companies, the physician networks, and proposed to invite the health plans into the pool. But here's the catch. For health plans that want to join in, they have to bring that physician access API that CMS is live with this year and not wait to 2027. And that's the incentive. If we do that voluntarily, beyond the regulation, we can equip doctors, nurses, care teams with the information they need to, in real time, interact and support these individuals who are in a more accountable relationship. And to me, Rob, that's the most exciting part of this feedback. We are where we need to be, but the market may not be aware and therefore demanding it be live. So that's the invitation. Come into the pool and join.
And I appreciate that, Anish. And I think you're noting here that we've got some capabilities that may not be well known. I'm also keeping track of the quotes throughout the day. And I think the ability to search for health policies that allow us to have nice things is maybe one of the goals I'm going to focus on from now on. One of the other topics that we've talked about a lot is really how to learn and how we're learning what works. How are we able to learn more quickly? I think Mina's shown that ability in thinking about where, say, CMMI pilots are able to inform the direction, say, of like the Medicare Shared Savings Program to understand what happens to components, not just overall models. And Will, you've done some thinking about how we learn in healthcare. How do we learn what works? How do we build better evidence? I want to see if you want to talk a little bit about where you see some promising directions in that regard that can help us accelerate the pathway we're on.
For sure. So I'm reassured and excited to hear so much conversation over the course of the day about the importance of sort of rapid learning and understanding what's happening in the delivery system when payment reforms are in place. I also am a little embarrassed and have a lot of humility about hearing these conversations as well, having led the evaluation group at the outset of CMMI. You know, when CMMI first was stood up, the statute was really clear around how to test models to determine whether or not they could be certified by the actuary and then ultimately scaled by the secretary. And I would say that we over-indexed on the statute and under-indexed on the magic of what CMMI is. So when you put out a new payment model, you create a new set of incentives. You don't actually change anything. You just change you change the business context. You change the incentives for providers to care for patients differently. You reward them in a different way. You don't actually determine, generally speaking, we're rather non-prescriptive in terms of what the providers are expected to do. We give providers a ton of flexibility to build the health system that they think to institute and implement the delivery reforms and the care coordination programs and the physical behavioral health coordination, integration programs, the better use of data programs that'll drive better results. And then there's a ton of flexibility and a ton of variability in terms of what providers initiate and implement. It doesn't feel like the right answer at the end of and it takes a long time for a lot of these things to be implemented and stood up. It does not feel like the right answer at the end to say yes or no, this program worked or didn't based on, did it meet some threshold, savings threshold. These are incredible experiments with really, really rich efforts that are driven by very passionate people to take really, really good care of beneficiaries. And we have not done a good enough job of understanding those underlying delivery reforms, what works and doesn't work. We have not done the right kind of codification of like, what are the programs that providers are testing? When do they start them? Who do they target them? How can we learn across a model about what is working within the model? Really understanding what's working within the model is probably the most important thing for us to figure out. And ultimately, our ability to do a better job of capturing, distilling, synthesizing, and creating a bit of a playbook for providers around how to be successful, I'd say is a job of CMMI and CMS. And it will unquestionably make Mina's job easier. You know, as Mina's trying to continually improve on and evolve the MSSP as an example. You know, Mina probably won't say, you must do this physical behavioral health integration program because these are the results, but she may say, we highly encourage you to use this kind of a model because we just demonstrated that these are the results you might be able to expect if you were able to deliver or integrate or develop one of these models. So my sense is that there's a lot of interest in this now. Liz Fowler and the team at the Innovation Center is talking a lot about this transformation agenda, but this is something that can't go slowly. It has to go fast. We have to get better at learning what works within models. We have to get better at like identifying, cultivating, curating those interventions that are most effective. We have to get better at like creating a bit of a playbook so that we can encourage providers to leverage the best evidence out there about what to do in order to drive better population health and better, chronic disease management, better health of the populations they serve. And I do think it's a really central priority for CMS and CMMI as a real sort of accelerator of that work.
And I'm going to the Slido here to get some questions from the audience.
Rob, can I just take it? I'm going to call the audible because I want to share. This is an example to take what Will just said, maybe to the point of all these pieces coming together. One of the first models that scaled was the YMCA Diabetes Prevention Program. And I want to make a comment about it because I think it has relevance to what we could do faster. So at the time when CMMI ran the funding for the program, the claims data on who's pre-diabetic was like you could have a very huge number of people qualify. And if every one of those folks were given the $600 voucher, I don't think we would have had a positive ROI. But the model evaluation involved EHR data to make sure that the population that qualified for the voucher had an impaired fasting glucose of, I don't remember, 140, I can't remember the exact number, but a number.
Right.
That's in the EHR, not in the claims data. By incorporating the EHR data to be more precise on the eligibility criteria, the actuary said in the paperwork to sign off certification that it had a 4-to-1 return on investment. But that was a rare learning health system. I can't think of a single model evaluation report since that's incorporated EHR data in being a bit more precise about whether what we did worked or didn't work. And I think about all the comments about chronic care management doesn't work at scale and primary care first didn't work at scale, all the reports that are like modest results. I wonder if buried in there is a lack of integration of the EHR data to have a much more precise view as to who would benefit from the intervention. Are we saying models are not working, sending the wrong signal, when what we should have been doing is precisely tuning the data sets? That's missing from the evaluation framework. And now with the systems in place to share, we got to close that gap.
So can I really quickly build
Okay,
on that?
real quickly.
I know you've got more to get to, but this is, I think, really, really important. So the CMMI has a big evaluation budget. It's largely used to do these different kind of evaluations to assess whether or not the overall model is successful or not. The ability to do these subpopulation analyses on data that's already there. This is not like, these aren't expensive analyses, and they're not hard to do. And particularly now that we have better integration of clinical data and claims data to really be more personalized and say, these are the populations that benefit most from this program, we can start being much more prescriptive. Not prescriptive, we can be much more
precise,
thoughtful about how to build the right kind of accountable care system program that'll deliver the results that Mina would love to see every day.
Well, and actually, Mina, if you don't mind, I may.
My name keeps being
Your
mentioned.
name keeps
I
being
know.
mentioned here, so I want to give you the chance to respond. Clearly, you are in many ways the customer of a lot of this evidence that comes to you, and would love to know from your perspective, what type of evidence are you looking as you're thinking about what to scale up to, as we said, 65 million Americans who are in your program? Are there specific things that you're looking for, whether that's for components, for overall models, that you think about as you put things in the Medicare Shared Savings Program, Medicare Advantage, other aspects of regulations that are under your purview?
Yeah, I think, building off what Will and Anish had said, the way that CMMI models have been evaluated has been very narrow, right? About, does this model generate cost savings? And I think Nancy Ann had mentioned before, not considering necessarily the spillover effects that happen outside of the model as soon as you announce something that Medicare is doing,
right?
Not considering that, you can be improving care, improving outcomes, improving patient experience. So as we have been, and considering that a model often has many different pieces to it, where the model in totality maybe did not meet that statutory threshold, but there are components of the model that could make sense. So we have been analyzing things in that way, really being able to see what has been the impact on outcomes, what has been the impact. I mean, also thinking about workplace burden. We know that we have workforce shortages, and where are there ways that you can help with a team-based approach actually alleviating some of the burdens, the moral distress that healthcare providers have been feeling, right? There is a broader scope to think about care delivery and transformation that we have really taken on as we are looking at the Medicare program. And I think it is incumbent on all of us, to what Anish said, to really get more precise with the data, to be able to bring in, if we want to care for people as people and not just as a sum of all of their ICD-9, ICD-10 codes, then that means we have to have that data that looks beyond the ICD-10 code that matched to that E&M, code that matched to that CPT code. And so I think, Anish had mentioned TEFCA and the work that ONC is doing. I think that's really critical if we want to get where we all want to get to, so that we can have data that is crossing all of the experiences that people have. And then that's what we can use to say, okay, this is something that we can, to the point that Will made, we can encourage, we can pay for something, we can have quality metrics that reward for something, so that you can move in the direction of changing care that we are all talking about today.
Well, and actually that is an excellent transition to one of the questions that we've gotten here, which notes that policymaking is often done in stories, that we think about stories of changes in your care, your family's care, changes to the way that maybe physicians or other clinicians are practicing care. And one of the struggles in the value-based payment movement to date has been we focus a lot on the incentives and we have a little bit less on the stories and how actually care will look different for those who are practicing, for those who are receiving. And maybe turn to any of you who want to jump in to say,
I'll jump in.
I was to say, how is care actually going to look different tomorrow, thanks to some of the work that's happening right now?
Well, I mean, as I mentioned, I was practicing medicine before I took this role. And the stories of me taking care of my own patients absolutely drives, some of what I do. And I would say, I mean, this has been kind of a more health policy audience, so I haven't regaled you with all of those stories.
But regale.
But I will regale. But, I think there are three big things that really bothered me as I was leading care transformation. Number one, that people get lost in all of the wonkness, right? And all of the talk about the benchmark and the reward. And at the end of the day, you're talking about someone who wants to be healthier. They want to be able to live at home. They have family members who are trying to help them be healthier or are themselves affected when their loved one is sick. And far too often, I think that person can get lost in all of this. And that has been a focus for us as well, to really explain. If you walk on the street and say to someone, what do you think about value-based care? They're just going to look at you like you have three heads. But if you say to them, hey, maybe you don't have to tell for the 10th time what your allergies are because nobody has bothered to coordinate, or you have people prescribing you the same medication because they weren't talking to each other, right? Really putting it in those terms. The second we talked about the big spreadsheet that we had in 8-point font of like the 500 quality metrics that we were being held accountable to, which everyone's arguing about, is diabetes control hemoglobin A1C greater than 8 or hemoglobin A1C greater than 9? I'm like, time out. How about just taking better care of the diabetic? And the third being about the pilot graveyard. But I will regale with one story. So when I was in my last year of residency, I had a gentleman who was coming in. He had a large tumor in his throat. We were doing a total laryngopharyngectomy, for any of you that know that I'm an ear, nose, and throat surgeon. So basically removing his entire throat and back of the throat and his voice box and taking tissue from another part of the body to reconstruct. So I was reading through the clinic notes as he's, going to come in for the surgery, because I was going to be, leading the team caring for him in the hospital. This was before EHR. It was all handwritten notes. So the attending had written that he drank 33 beers a day. And I thought, okay, doctor's notes, they kind of look like EKGs, so I'm like, maybe I didn't, read it properly. So when I met him that morning in pre-op and I asked him how much he drank, and I said, it said that you drink 33 beers a day. And he said, yeah, that's probably about right, because he drank the big cans, the 40-ounce cans. So needless to say, so do this big surgery. He needs to be in the ICU because of alcohol withdrawal, right? Having an Ativan drip to prevent, DT. He had zero nutrition, right? Because he's been drinking 33 beers a day. So with no nutrition, his wound couldn't heal. So his wound completely dehisces, and it's here. It's this complex wound packing that my team and I are doing, 3 times a day. Also, he has no family support. So who's going to come in to then learn how to help do this wound packing? And so he was in the ICU for a good 2 weeks. We were trying to figure out where he could go, because now he had these complex wounds that needed to be cared for. And I think that is as you can probably hear, that is something that haunted me, for far after his leaving the hospital. Well, what did we do to help his actual health? And I think that's where all the work, integrating behavioral health with physical health, really driving towards what are the social circumstances, the community circumstances of people we're caring for. Because I think none of us, I think, would consider getting that patient discharged from the hospital as a success story.
I think No, I said amen.
Amen. Amen. So on the other side, I think the there are incredibly positive stories that we have to do a better job of telling. And
You wanna
anybody
tell
who
one?
I will tell, I mean, I'll tell a genre. So I spent a lot of time with the I led the senior focused primary care business at Humana. And it's a team-based, fully capitated. The team huddles every day. They've got it's sort of a really broad team that manages the health of every patient that's seen there. Social work, pharmacy, care manager, somebody that helps with billing, so everything. Every single day, you go to the huddle and you see something beautiful. You see that care manager share that, yeah, I did call this patient on Thursday night. They had, we're having that problem, and we helped them with it. This person went home from the hospital, didn't have food. We have a benefit. We were able to, you just watch a team that's focused on improving the health of a population work, and you watch it day in, day out. You watch the interactions, you watch the way they work together. You feel so reassured about the way in which a value-based oriented primary care clinic can work. So, I mean, it's very easy to tell these terrible stories about how things are falling through the cracks and we're putting lipstick on pigs. But if you take a good look at places that are putting both feet in the canoe and they're all in on value-based care, you will be amazed at the number of really enriching and reassuring and totally lovely stories about humans working really well with other humans.
I'm the tech guy, so I'm not going to tell a story, but I'm going to do the policy tech story. Where would I see the sleeper story to follow? Voluntary alignment. So we've had a paternalistic model for value-based care. It's sort of all set by attribution rules, and the patient's sort of oblivious to it. They get a letter. I don't even know if they know what that letter reads. It's kind of complicated. But CMMI introduced this idea that physicians can introduce a form. It's paper, but you can have a digital version that allows you to ask the patient to join your practice because you're offering more coordinated care. That's a pretty novel idea. And I think the first year it happened, I looked at the data, about 10% of the attributed population was actually those who opted in. I think there's something to be said about putting that model on steroids. I don't know if any other plans do this. I think it's kind of a unique to CMS thing, but it's an opportunity. To get to more stories, you got to educate the population as to what this is about.
Yeah.
And I feel like this is a great area where we could bring more innovation. And we had AI on the panel title, so there's been nothing said about it. Keep an eye on principal illness navigation. The new billing code that Mina put out, that's going to give people a little bit more of a peer support. That vehicle will likely be powered over time through decision support that will look after your best interest. You're taking meds that are costing you more out of pocket. Your navigator might help you find a lower cost option. You're not getting the right preventive care services. The navigator might give you a hint on what to do to close the care gap. So there's some opt-in areas that will naturally result in stories that may be the sleeper component of the infrastructure.
And I think with that, I am being told we need to end this session. So, and I think let's thank our panelists.
Thank you.
And appreciate that we were able to show the stories behind just the incentives. And so bringing back up Mark McClellan to talk about going to take this to the next level from a biomedical point of view.
Great. Thanks very much, Rob, and thanks to the whole panel for an excellent discussion. So that brings us to our final session on advancing evidence development for biomedical innovation and better clinical care. The opportunities for biomedical innovation to improve health outcomes have never been greater. GLP-1 drugs and innovative therapies for other high-burden chronic conditions, including cardiovascular disease, neurodegenerative diseases like Alzheimer's, better understanding of disease mechanisms, enabling more progress on many cancers and rare diseases, transformative cell and gene therapies. Yet, as we've heard about during the afternoon today, our speakers and the sessions have highlighted that despite unprecedented biomedical capabilities, US population health outcomes have been headed in the wrong direction for more than a decade, with only some improvement from the emergence from the COVID-19 public health emergency. So we've talked a lot today about directions to change that. Innovative approaches in Medicaid and other federally supported state-led programs, better aligning them to pay for and support better health outcomes, aligned policies to inform and enable healthcare and public health and community-based collaborations to improve community and population health, steps to modernize our data infrastructure, incentives, and opportunities to learn, to translate the promise of value-based healthcare into real, coordinated, longitudinal care that makes a difference in patients' lives, as we just heard from the last panel. All of these sessions have highlighted the need and opportunities for better data and evidence to guide these reforms in clinical care and make a difference in the health for Americans. So in this session, we want to turn to how we can accelerate the development of practically relevant evidence that's feasible to collect, including in busy and stretched healthcare practices, to help them build the capabilities and the knowledge to sustain new care models, to improve access, avoid unnecessary costs, and really move the needle on health outcomes for our overall population, for people with currently unmet medical needs. There's a lot to learn in this process about medical products as they come to market, but also after the initial clinical trials that bring them to market, where most of the data that we've talked about today comes from real-world clinical practice, potential real-world evidence. And FDA and NIH, along with other federal agencies that are responsible for and leading the way in advancing biomedical innovation evidence, are undertaking important new initiatives, major initiatives, to support this whole life cycle clinical research enterprise. And that includes some new initiatives that NIH is developing. It includes FDA efforts to accelerate the translation of evidence on promising new drugs into clinical trials and then learning more on the market. And that's what we want to talk about in this session. So I'm very pleased to welcome up to the stage two distinguished and very busy federal leaders on these issues of evidence development. Monica Bertagnolli, who's the director of the National Institutes for Health, and Namanje Bumpus, who's the principal deputy commissioner and acting chief scientist of the U.S. Food and Drug Administration. Thank you all both for coming up in this session. I do want us to talk about, great to see you all in person. I do want to talk about these promising new initiatives, the challenges, the practical obstacles and opportunities to really develop the evidence that can drive these transformational changes in care and the better data that we have to support all of this. So let me just ask you all to begin. What do you see as the most important opportunities at your agency? I know you haven't been there that long, but you are an NIH veteran. The most important opportunities to make progress on advancing evidence to impact healthcare and improve health outcomes for the U.S. population. I know you both have thought about this a lot, and Monica, I've heard you speak eloquently about the population health challenges and this disconnect that I just mentioned.
Well, thank you. You know, that last session was like a perfect setup for this one, I think, you know, because we are so complementary. And one of the things I want to say from the beginning is that it's really amazing to be part of the big HHS family, right? Because the things that are going on at CMS, the things that are going on at ONC, you know, the
CDC,
all of us, we really are at a time when what we are doing complements each other, and the more we communicate, you know, the better we are. So that's really exciting. Okay, a couple things. First of all, man, fundamental science is so cool. We now have a complete cellular map of the human brain. It is so cool. We've identified that exist proteins that silence the X chromosome, you know, prevent, you know, solving the problem of gene dosing in women, but that probably is responsible for the huge driver for autoimmune disease in women. You know, we're finding so many cool things in the laboratory, but the work of NIH is not finished when we make scientific discoveries. The work is only finished when people are living long and healthy lives. So as cool as the fundamental sciences, and we love delivering new therapies and new approaches, we've got to be where people where we're not succeeding in people living long and healthy lives. If you look at the map of the United States and you map biggest problems with substance abuse, biggest problems with suicides, biggest problems with gun violence, biggest problems with not, vaccine hesitancy, and highest cancer incidence, highest mortality from cancer, and then finally lowest life expectancy. It's the same map. Every single one of these things. Oh, I forgot one. Maternity care, perinatal and maternity health deserts. Places where women just can't find good perinatal care. It's the same map. So we've got segments of our population that really were not doing things right. And so what we really are launching at NIH is, one more thing. What do? NIH is 27 institutes and centers, and they all have their own little focus, National Cancer Institute, NHLBI, everybody's got their own disease interest. And there's not previously been a focus at NIH on primary care, on the whole person, instead of episodic care over a life of care. So 2 things we're doing. First of all, is a new major emphasis on primary care as our laboratory, our source of learning how to do better for people. And then number 2, focus of that primary care environment on the communities that have these really awful disparities in health outcomes. And then the last thing I'll say, which is so wonderful that, leverages off of the past panel, is that we are going to get into primary care practices. We are going to learn from the clinical care environment, and we are going to use the electronic health record as a source of our data. So that, no more you have the research data collection in some parallel electronic system, whereas we now have an electronic health record. And I think that if we can do this, if we can start learning from this environment and using the EHR as our source of data, we can also drive everything the last panel was talking about. There you go.
Monty?
Thanks. Lots of points there. I think to start off with what we just heard about fundamental science. I think that making sure that I'm a basic scientist, so people like me, but that we're connected in this system. As you're learning things coming from primary care, we need to make sure that we filter it back to the early stage so that we can fully leverage all the information. I mean, there's an impact for evidence generation across the whole life cycle of a product. So making sure that our basic and translational scientists, often there can be these silos, but really bringing those groups together. Another thing that I think that we can do is help ensure that there's education and teaching around evidence. What does it mean to generate evidence? I think that there isn't always full understanding of that within our community of medical and biomedical healthcare professionals. So how can we all play a role in that? What are the opportunities? Certainly that's something that I think we can help vocalize. Innovation around digital health, decentralized clinical trials. We have efforts around that, certainly at FDA and collaboration with NIH in that space. But I think that there's a lot of opportunity as far as what we can try to advance at FDA there to ensure that those are fully leveraged and really enhancing the evidence that we can generate.
And Namandi, just to follow up on some of that, as you mentioned, your background comes from basic science. That said, FDA has tried to do a lot to move from basic to clinical trials and on out. Translational science, what's called regulatory science. I don't know if we have a great word for this, although it seems really important. And I've heard you and Rob Califf talk a lot about this whole life cycle concept. I remember in my days at FDA, we heard about that a lot for medical devices, where a product gets developed and then it gets on the market, the surgeons figure out how to use it better, it keeps getting innovated further. And people used to think, think more about drugs as being, well, it's a molecule. So you do the study, maybe do a few label extension studies, but there's not this kind of whole life cycle approach. And whether it's for rare diseases where it's just hard to get enough people to do a traditional randomized clinical trial, or for, as I mentioned at the outset, some of these more common conditions where drugs may look good in a clinical trial that gets it to market, but may, really raise some concerns or questions about, if the healthcare system isn't set up well to deal with it, if there are opportunities, say, as we'll hear about in a few minutes, for some of the gene therapies potentially to really bring down the cost of manufacturing and the reliability of the platform, or to look at long-term outcomes or effects in patient populations, Monica, to your point, that weren't typically included in the traditional trials. Can you say a little bit more about the sort of the FDA vision for this life cycle? And just wanted to check, this really does apply to drugs, biologics, other medical products, not just traditional areas and where people would think about life cycle.
Certainly, the life cycle of a product, and also where FDA, so I think food, there's opportunity even in the food space to think about how we use evidence generation and understand more about.
Certainly important for population health.
Exactly. So there's a lot of opportunity there. So a few things, but one thing I mentioned, digital health. I do think that there's a real opportunity there as far as the types of measurements and things you can do, bringing it to the people, making it so that participation is more accessible to people. Certainly there's opportunity there. And, being able to collect and analyze data in real time, potentially, I think certainly can make it more robust when we're trying to understand endpoints. And even things like, looking at biomarkers, looking at utilizing and leveraging local facilities, leveraging novel platforms for measurement detection. There's a lot of opportunity there. So there's this intersection between kind of the basic research portion. And, at FDA, we do research too. So we're part of that greater community who's really developing some of these methods. But that research component, and then thinking about how we can roll them out. But again, when we do, how do we feed those data back to the researchers or the translational folks to really ensure that they're leveraging that? And I think, as you mentioned, rare disease is certainly a place where it could be really useful.
And Monica, you mentioned the 27 institutes, but there's not a National Institute of Primary Care, right? But yeah, I wonder if you could talk a little bit, since we heard so much today about this push towards accountability for population health, the data infrastructure you mentioned, building a lot off of improving healthcare data to enable primary care practices to do more. And even thinking about primary care, not just as like going to your doctor's office, but a primary care team that works with community health workers, that's out in the community, that says, we heard about earlier, trusted connections. Yet that's not traditionally part of most clinical research studies. So can you say more about the initiative that you're undertaking?
We want to rethink clinical research, even clinical trials, and instead think about it's bidirectional, meaning our institutes and centers have areas of concern, research questions they want to ask, but our community and primary care practices have questions that are meaningful to them. We're not going to assume we are going, we want to study the same things. We want to listen to the patients and the primary care providers and see what are the problems in health that we can study to find solutions. And then finally, so the concept is we turn the clinical care environment into a learning environment. But we don't want it to be, we want it to be a rigorous learning environment. All the scientific principles, hypothesis generation, but hypothesis testing, solid data. And we've had many discussions with FDA saying, hey, as we get ready to plan this system, we want our learning environment with these communities, these private practice, to be able to generate the kind of data quality, experimental design that will let FDA make regulatory decisions. Maybe not for everything, but we have to have that capability kind of built into the system. So I think for too long, there's been research teams and clinical care teams. We want to make them the same.
And I know going back, thinking about your history a bit previously at the NCI and doing a lot of work, you talked about the data infrastructure to support this. You know, one thing that these busy primary care practices are probably not going to be keen on is having to separately abstract and recheck data and so forth. Can you say a little bit more about your experience there? Because this is not new, and you helped develop so-called M code and data standards that now seem to be making their way into, as we talked a lot about today, since this is a health policy and transformation conference, the Office of the National Coordinator and what is possible through an electronic health record. But that isn't the usual way that clinical trials are done.
I know.
You're really going to change that?
Well, okay, but think about like how kind of silly what we do today is, okay? Yeah, I've been a clinical trials researcher in the clinic many years. What do we do in the clinic? We see a patient, we record data from that patient in the electronic health record. They're on a trial. So we take that same data that's in the electronic health record, and then somebody, usually a coordinator or somebody, sits beside, and they take all that data from the EHR and manually transcribe it over into another electronic data collection format. And then, just to add insult to injury, then we send a monitor to look at this electronic record to make sure it matches that electronic record. You know, does this make any sense? Now, I mean, I'm being glib here. What are we going to have to do? What are we going to have to introduce in the electronic health record if we're really going to be able to do research? We have to be able to pre-populate our records that we need for research. We're going to have to be able to introduce a query and response capability. Dr. McClellan, you didn't tell us, you didn't get a patient's, CAT scan at day 21, and we need that. Please do that for us. That needs to be part of the electronic record that comes in with the patient that fits into the routine data flow.
Data quality and data standardization, really, so that you can utilize it.
Exactly. So there will be no source document verification. The source document is the EHR. We have it there.
And Maji, FDA has done, and Monica, I know you're familiar with this, a tremendous amount of work with some congressional bipartisan push behind it to take steps to clarify what constitutes valid, reliable, so-called real-world data as a basis for that fit for purpose use in clinical trials and studies. I know a number of guidances out over the past year, conferences, et cetera. As you know, we had a recent two-day conference that Duke-Margolis co-convened with FDA's Drug Center that was really about, look, there's a lot of guidance out there now. There are a lot of opportunities to do this, but we don't seem to be seeing as much take up and a lot of inertia in getting away from the current approaches. And that conference is notable for me in how much there was frank exchange on the FDA CEDAR side with regulators, also participants who were leading scientists, clinicians, patient perspectives, that basically said, look, yeah, there's a lot of guidance out there now and a lot of potential, but we're still seeing challenges in what people refer to various ways, but basically change management and kind of changing the expectations, changing the culture, getting to more certainty. I was particularly surprised, and not surprised, I mean, not the right word, but impressed with how much the FDA staff were basically saying, look, you got an idea, you think there's guidance, but you're not sure it applies, come talk to us. And yet also on the industry side, the funder side, maybe some inertia in moving in that direction. So I think it's for both of you. This is a big change. It's really sort of a culture change. We've got the technical capacity to do it, but I guess like all culture change, it tends to be slow and a lot of hesitancy. What do you all think about accelerating that? How can we do it?
Right, it is a culture change. I think that, CEDAR, you mentioned that workshop, I mean, they really are wonderful and have experts on this and are really advancing it and have been for a long time. Certainly dialogue like this, but I think that the more that we can start to establish these, networks working and really bring everyone together. I still think that there can be, researchers who aren't necessarily aligned, or so it's thinking, I think, about the community, who we really need together to advance this. But you're right, it is going to take time. And if there can be some examples, I guess, then that always inspires people. So a few, I think, designed kind of examples and teams on that, then that gives other people some inspiration. And we're always thinking about ways that we can try to spur innovation in those ways. And I think we're seeing some progress.
Some examples coming up?
Oh, yeah, some examples coming up. And, I have to be honest, we're not ready to publicly announce exactly. But I can tell you that there are now use cases fully underway that are collaborations between CMS, CDC, and NIH, for one. Think big registry where we all need the same data and we're going to collect it once instead and, distribute it for the various uses. Going to collect it in real time very efficiently with structured electronic health record formats. So, that's one, that's collaboration across 3 agencies. And then we've got one under development with FDA that's going to look at, the post-market setting for how do we do a really comprehensive look at some class of drugs and what's happening out there in the environment. And what these use cases are doing is they're developing the data standards that we've all agreed on across all of us, the data standards, which, since the ONC is very much a part of our world, of course, they're going to be completely compatible with everything that's already been, you heard talked about. So the data standards, the collection techniques and procedures, and these are going to be released in a pre-competitive open source environment. And they're going to say, okay, for all of our industry partners, the whole broad world, we need these are what we need delivered.
Well,
and there's a great, drive behind delivering these information because we all need them.
I know we're about out of time. I did want to ask one more transitional question to our next panel, where we're going to have Dora Hughes, who I know both of you know and work with and are involved in some collaborations that you can talk about, but probably some that are still in process. Yeah. And some leaders from doing clinical research, including more real world embedded clinical trials. We're going to ask Dora about how CMS fits into this. I'd like to give you all a chance to help her out now. We heard from John Blum, Meena Seshamani, other leaders there about just how committed CMS is to move towards paying for better health, to move towards supporting better data infrastructure that relies more on the not just traditional insurance claims, but electronic record data, as you said, is more interoperable now, and especially if it becomes more relevant for payment, probably going to get even more accurate and reliable. We heard about CMS and CMMI initiatives to learn more rapidly about how to change practice using new medical products, embedding them into care models. Just to tee up what's going to follow, comments about how you all can work with CMS and these initiatives of moving towards value-based care, payment, quality improvement, better data.
Okay, I can start. Absolutely. I really feel we're at an inflection point. There's been enough understanding that this is the way we're going to make progress. And now it's time just to do it. Get it like you heard described before, just to put a stake in the ground and say, we are going to work together and deliver this exercise, this effort with a tangible benefit to our ecosystem here. And I'm just so thrilled to have such wonderful partners, such welcoming, enthusiastic partners across the agencies of HHS. It's really pretty thrilling, actually.
Yeah, I would second that, certainly. I think that there's a lot of opportunity for learning and on the research front. And I always put in, like I said, a plug for, bringing in those basic translational scientists. I think that we have not had much interaction on this front, But that if we start doing that, there are new questions that we can ask scientifically that I think can help feed the system. So I would say let's broaden even some of those scientific interactions.
All right. Well, I want to thank you both for the time today, the vision, the commitment, and the collaboration that you're describing. I want to have you back to talk about some of those next steps, hopefully soon too. Thank you for teeing up a discussion where we're going to get into what some of these actual applications can be. Really appreciate your joining us today.
Thank you, everyone.
Okay.
And for that next conversation, I'd like to welcome Dr. Marianne Hamilton Lopez, Senior Director for Biomedical Innovation at Duke-Margolis, up to the stage along with our panel to discuss the next steps on these issues. You're right behind me.
Right there. All right, I'd like to welcome our panel. We have Adrienne Hernandez from DCRI at Duke University, Roy Hertz from Yale School of Medicine, Fyodor Urnov from UC Berkeley, and already well introduced. We have Dora Hughes from CMS. And I'm going to start by we just had a pretty inspirational panel, almost a call to action, where we heard that it's time to rethink clinical trials and reimagine evidence generation. So Dora, I thought this was nicely set up for you, but I would love to hear, as we're thinking about more pragmatic trials or collecting real world evidence, especially in more diverse settings that are non-academic as much. CMS has done a lot to, as we've heard today, about interoperability of data, about quality improvement, and generating and having better real world evidence is one of the agency's strategic goals. So where would you say are the key steps to reaching these aims of kind of reimagining our evidence generation pathway?
Yes, thank you for starting the question. Thank you for inviting me to join the panel. I will have to say I'm glad I was able to listen to the last panel, because when Monica said we're not ready to talk about it publicly, I thought, oh, we're not? And so
no, she's fine. You can right ahead.
I got myself into trouble right off the start. But I do have to just truly commend NIH and FDA for really taking the lead on really pushing across the federal agencies for us to think, how can we collectively pool our resources, our data, really leverage our different authorities to generate evidence that will be useful across all of our programs and policies. And I'm sure, as all of my CMS colleagues before me probably share, I mean, we're very excited about the potentials and the prospects. I would say for us, even internally, even as we're working across the agencies, for us, we're already seeing a number of use cases, even some recent developments that I think have really helped to show us the potential. One, I'm sure you've touched on the cell and gene therapy model, but even in developing that model, I have my CMS Innovation Center hat back on. We started with talking to NIH. Tell us the science. Can you link us to your providers, your experts, so that we better understand the course of disease? What should we be focused on in this model? Can you introduce us to providers who can talk about sickle cell fertility, for example, really just connecting us to the research, to the evidence. And then on a parallel track, we were also talking with our colleagues at FDA. Colleagues at FDA are always very careful to tell us the bare minimum until they get closer, but even early. What are some of the indicators we should be thinking about? At CMS, we care about the costs. We want to know about the numbers of hospitalizations, for example. But what are the outcomes for a potential model that would help you understand what are the priorities for you in terms of phase 4 and all of that? And so really just having this dialogue at the front end as we develop the model, on the back end as we're thinking about implementing, what are the outcomes that matter, what should we be negotiating? It was really an excellent proof of concept for how we should be moving forward for the next wave of drugs or devices or whatever the treatments that might be coming down the pike. But of course, this is not the first, we're not just starting here. As many of you know, through our national coverage determinations, now I have my CCSQ hat back on, we have in many cases, when we are feel that we don't have enough information to determine whether a item or service is medically reasonable and necessary, that's our standard. FDA is safe and effective. For us, CMS, is it medically reasonable and necessary? In those cases where we feel like we don't have enough evidence to comfortably make a decision about whether such an item is reasonable and necessary for Medicare beneficiaries who are older, sicker, frailer, et cetera, then in some cases we provide coverage with evidence development, meaning that we will cover in the context of a clinical trial or a registry where we can gather more evidence and we could make a more solid decision. And as part of that, we've done that for many years now at this point, but last year we announced a new pathway for breakthrough devices, working again with FDA, the Transitional Coverage to Emerging Technologies, or TSATE pathway, where we're really trying to think through, this is what we've heard from industry who have gone through CED. Here are some of the ways we can streamline, we can make it more transparent, we could accelerate, and we could, again, gather the evidence that truly matters for us on our end, but also for the providers and for the beneficiaries who we ultimately serve. So I'll stop there. I know I just said a lot right there, but I feel like at this point in time, we're very much excited about what we can do ourselves at CMS, building on some of the work that we had previously done, but even more so, how can we expand upon that? How we're able to augment that with a true and meaningful partnership with our colleagues at NIH and FDA especially. Although, if we have time, I would love to also talk about our work with CDC, which is also quite exciting.
Excellent. Well, I will ask then some just reactions from the others here on the panel. You all are very involved in clinical trial work, but in different areas. But from the many different ways that you have done evidence generation to increase the impact of biomedical innovation, where do you see the most opportunities for progress, especially to meet all of the kind of aims that were just presented? You want to start?
Yeah, well, it's just exciting just throughout the day. You hear this theme about how we're going to have better systems that are interoperable and better data. And so that's going to really help improve health. So we can take advantage of data science to actually know where we're going and actually have better care for populations. That process is also going to be really great for the infrastructure for clinical trials. As we just heard just now, it seemed like this broader goal of getting clinical research or clinical trials everywhere for everyone, you have to have a really different system, and you have to meet the patient where they are. And so that type of infrastructure allows us to do things that hasn't been done before, to do it at scale. And there are these examples that have been done to actually do clinical trials at someone's home. Imagine that, having that trial meet them as opposed to the patient coming into the so-called ivory tower. I think the other thing is that as the systems are getting better and with a greater data integration and hopefully better timeliness, the latency is also reduced. And so then we can speed the cycle of everything we do. And so in the past, it would take a year, 2 years actually before a clinical trial will get launched. It would actually take several years to identify the people and recruit them, and then several years of follow-up. And so a 10-year cycle getting shrunk down to a year is actually within reach.
That's excellent. And just as a follow-up for these examples that you're seeing, like being able to do trial work within the home, for those types of innovations, are we at a place where we can start to scale them beyond other settings besides kind of where they're starting in academic centers?
That's actually happened already. You know, silver lining of COVID is it forced us to do things differently. And so we've had, for example, platform trials like Active-6, where testing different medications against placebo that's regulatory enabling, and had a hybrid approach where people can enroll at a community center, a healthcare system, an academic center, or at home, and actually literally enrolled people from every corner of the U.S., Alaska, Hawaii, all parts of the U.S.
Roy?
Well, you know, the theme of the day has been getting better care to patients sooner. And, you know, the clinical trial system as we have it now just doesn't work well enough. The trials are old, they don't have the best science. They don't get to the point of care. We're not getting diverse populations on study. So we definitely need to do something different. So I'll tell you just a little story from cancer that I think shows how all the agencies have and all the stakeholders have worked together. So about 15 years ago, the National Cancer Policy Forum of the National Academy of Medicine commissioned a report. How can we revitalize clinical trials? It was actually chaired by the late John Mendelsohn. And that started the National Clinical Trials Network. So soon thereafter, the idea was, can we do trials, master protocols where we can use science, genes that we now have discovered that are leading to new drugs? How do you find a patient who's a 5% PI3 kinase mutation that might only be 5% of the population? So we set out to do a lung cancer master protocol. And we did this as a public-private partnership and had a lot of help from the FDA, from the Friends of Cancer Research. We used the foundation of the NIH as a common broker, brought all the clinical trial groups together. And we actually created a funnel where we could find patients from 500-600 sites through the network. They all, through the money that came in through this network, they got screening, they got profiling, which would not have been paid for. And then from that, we then matched them to drugs, bringing in the pharma companies together. You can imagine it's a very complicated sort of relationship, but managed by a common broker, the FNIH, with everyone's buy-in. We brought science, we got patients on trials. And while it wasn't great, we had about 8% patients who were Black on the trial, which is pretty low, but it was about twice what was going on the trials before, a small percentage of Hispanic patients. And from that, long story short, one arm of that trial, one sub-study, came out positive. It was a small phase 2. So then this is where it gets really exciting. So then we call up the FDA, Rick Pazder, Harpreet Singh, with our partners. It's a large group. I speak on behalf of so many people. And we say we want to apply for breakthrough designation. And we did that, we got it. But then we realized that if we were going to do a big phase 3 trial, it probably would cost $20–30 million and take 4 or 5 years. So that launched into the FDA challenged us, and some of you probably know about this, and said, can you do a pragmatic trial? Can you do a more real world trial? And that's what is commonly referred to as the pragmatic lung trial. So what's the idea? The idea is we had a combination of drugs, 2 drugs that were put together. The detail's not that important for this discussion, but they were both already approved. They were both available through Medicare. They could be obtained at any site around the country. Patients and physicians knew how to give them. So all we really need now is to say, does this combination meet a survival endpoint? We already had a small phase 2. Could we take it to phase 3? The idea was to do a simpler trial, not a trial that has so many endpoints that you can't put it all in the computer, as we just heard about, not a trial that's so expensive that requires large infrastructure, but something that can be done at the point of care at community sites. So what we did is we put a group together. We worked closely with the FDA, with the NCI, Monica, who was just here, very, very supportive, and we pulled it all together. And it was very funny as we designed the protocol. We were encouraged to take things out, but people kept putting things back in because no one believed that this type of trial could work. One, the pharmaceutical companies brought their lawyers, brought their regulatory people. They were totally worried. They still are. But we did this trial. It's not a 40-page protocol. It's 10 pages. The consent form is a couple of pages. It's a trial that can be done at the point of care. Real world prospective data, minimal endpoints. We're not even getting CT scans for progression because we don't care about that right now. We just want to know if there's a survival endpoint. We're only collecting toxicities that are totally new. We're being very, very minimal in our data collection. And I don't want to talk too long. We anticipated we needed 700 patients for this trial. It would take 3 or 4 years. We already have 400 patients accrued in 1 year. Why? Because it's at the point of care. It's easy to give. Now, will it be positive? Who knows? But we're asking the question and we're getting drugs to patient quickly in real time. So I would say that this type of approach, and we can talk more about it, we need to replicate it in other diseases, in other settings, but it's one way to sort of get drugs to patients in real time quickly. And to sort of cap it off, 14% Black patients on this study, 4% Hispanic. Again, still way too low, but it's getting better because people don't have to travel. They can get it at their own sites. And I'll just end, just by saying that as I've sat here today, we've heard about how we want to bring science to trials. We want to bring trials to clinical care. These are trials that can be done as part of the regular clinical care. So this is, I think, what we need more of in cancer and other diseases.
Great, thank you. Fyodor, we've been talking about disease areas that are rather large or areas where we might need a a larger platform or population-based approach. But your work is primarily with gene and cell therapies, an area where we have a lot of innovation, a lot of hope, new discovery. At the same time, a lot of questions about the evidence, and also sometimes questions about price tags. And so when you're thinking about collection of evidence and where we could see some opportunities, especially for the gene and cell therapy space, where do you see the most opportunities to move forward to kind of this new generation or this new evidence rethinking that we are talking about today?
Well, first, let me thank Mark and leadership of the Duke-Margolis Institute for the honor of inviting a CRISPR gene editor to this meeting. Let me start with news hot off the press. 45 minutes ago, CMS announced that two landmark medications for sickle cell disease. One is a CRISPR gene editing approach from Vertex Pharmaceuticals, which costs $2.2 million, and one is a gene therapy approach from Bluebird, which costs $3.1 million. And CMS just announced that they're evaluating a plan to pay 75% of the cost. And obviously, we have 120,000 Americans living with sickle cell disease. And it is an extraordinary moment for all of us who develop such therapies to think about the fact that an institution the size of CMS can work with a manufacturer and a sponsor of a medicine of this size, and we can talk about these kinds of price tags. I think we have a unique opportunity to have my field, focused field of CRISPR gene editing of human beings, have quite a big impact on healthcare, specifically via the real-world evidence approach you described. But first, I need to describe an upcoming danger. And the danger is the price tag. The most recent approved gene medicine in my field is $4.25 million a person. The way I come at this is thinking about the issues of access, and I know several folks have spoken about this. At the University of California, San Francisco, which is our clinical partner, there's a group of clinicians led by Jennifer Puck and Mort Cowan who work with a disease that disproportionately affects children of Navajo ancestry. It's a rare genetic disorder. It's called Artemis deficient severe combined immune deficiency. I just want to honor the Duke MD PhD program. The clinical lead on our side is a Duke MD PhD alum trained with Mary, Matt Can. And the question becomes, here are 20, 30, 40 Navajo children with this. And, the CRISPR approach we're developing looks really promising, as does the gene therapy approach. What exactly is going to happen if we ever get this to licensure and it's $4.25 million? Separately, having spoken with Dr. Khan, I know that to treat that child, the family has to leave the reservation, their social network, their support structure, and move to this middle of San Francisco to live with the child. It's devastating for them personally. So many folks at this meeting talked about like the last mile problem of not just delivering the care, but what happens when you actually have to improve the life of a living human being. So I'm not going to sit here and hand-wring and be negative Nancy. I'm going to be Nancy realist and give you a specific actionable path forward, which is this. Folks, the human liver is completely gene editable. Happy to quote you papers from the New England Journal of Medicine that show this to be true. A dose of 1 mg per kg lipid nanoparticle harboring CRISPR-Cas9 messenger RNA and a guide RNA, 95% single gene knockout, single step, with no measurable off-target. This means that in a few short years, there will be a CRISPR gene medicine from Novo for metabolic syndrome. There will be a CRISPR-Cas gene medicine from Lilly for also metabolic syndrome or another metabolism-related condition. There will be a medicine from Moderna, also CRISPR-Cas, lipid nanoparticle for chronic obstructive pulmonary disease. The only question is, how long will that take? And that, in turn, is determined by how much clinical data we will have accumulated on how to effectively and safely gene edit people. And gene editing and gene therapy in general began here at the NIH, Steve Rosenberg, 1989. And what have we learned in 35 years of doing genetic engineering of people in the clinic? That the only way how to figure out how to do that safely and effectively is do this in the clinic. Not a single severe adverse event in the 35-year history of my field has been predicted in non-clinical studies. Every single SAE was a revelation from the clinical trial. So right now we have a challenge. We have to treat more human beings with gene editing to find out how to do that safely and enable Novo, Lilly, Vertex, Moderna to give us all of these amazing one-and-done medicines for metabolic syndrome and COPD. But right now, everyone is stuck with a $4.25 million price tag. I think private-public partnerships and a focus on real world evidence is exactly what to do. There are 2,500 infants born in this country every year with severe inborn errors of metabolism. We can CRISPR them. There are 100,000 folks with inborn errors of immunity. We can CRISPR them. The path forward lies through creative clinical trial design, regulatory reform. And I really want to honor Peter Marks, the head of the CBER, who's been remarkable at really understanding that it's one thing to try to approve Casgevy for 120,000 Americans with sickle. How do you approve a CRISPR medicine that just got freshly designed for one child dying of an inborn error of the urea cycle at Penn Medicine? I have specific examples. So the agency, the CBER specifically, has shown some regulatory flexibility. But then the question becomes, when we come to CMS with this platform approach where we can repair 50 children a year who would otherwise die, who's going to pay for that and how much is that going to cost? And the path forward, last thing I'll say, thank you for letting me speak at some length, is we need more small, nimble clinical trial evidence to determine what matters and what doesn't matter in the path to the clinic. That will reduce the COGS. That will enable a world where we can stop charging $4.25 million for a curative treatment and drop that down 10x, 20x, completely realistic. So wrapping this up, real world evidence from knowing how to safely gene edit people for their rare diseases, I'm absolutely convinced can pave a path to a broader impact of this currently niche technology on metabolic disease, pulmonary disease, autoimmune disease, as long as right now we talk exactly about what we're talking about, which is thoughtful gathering of real world evidence and enabling the payers and the regulators to create mindful regulatory and reimbursement policies.
Thank you for those comments. And you brought up, obviously, the kind of the tension when we, especially as we're looking at cell and gene therapy around innovation and payment and price and the questions about long-term effects. And but what it brings up is can we look to our evidence to give us decision-making information about outcomes, about prices, about all of the different things that we're asking of it? And is that this kind of new world where we are describing, where we're not just talking about the clinical data, but trying to find out all these different meanings of what this data could do for different stakeholders? And how do we get to that? I think it was described in the fireside that we could collect data one time and it could fit the needs for different decision makers. Do you see a path forward for that type of evidence generation approach?
One thing about the area that he was just talking about in terms of gene therapy is that as you have more evidence of the platforms that are delivering, the nanoparticles that are delivering the gene edits, that becomes the platform and you're changing the cargo. And so I think that's, if you just imagine this world where, maybe we'll have essentially biological planes that's delivering cargo to do a gene edit. It's actually molecular surgery. And so we're really thinking about that as like, what's the safety around that platform? And then what's the benefit of the CRISPR target? And, starting off with rare diseases, but you can imagine, again, like anything that can be edited in the liver, that can be transformational for common health conditions. And then also thinking about this, where there's actually going to be interesting ideas around precision payment, because you actually will have measurable responses. And so how that gets amortized over, say, a lifetime is different than what we currently have as a payment model.
I'm going to give you an example from a common disease, such as lung cancer. We have all these new drugs being approved, quite expensive immunotherapies. When the drug gets approved, we know it's safe and effective, but we don't know even how long to give it. I was just on a tumor board this morning, and no one can decide, should the patient get a year, 2 years? These are all empiric decisions. All these neoadjuvant and adjuvant therapies now, how long do you give the tyrosine kinase inhibitor? How long do you give the adjuvant therapy? So I think these are all questions that could be asked in a real world setting. We should be collecting this within our hospitals. We should know these data. We don't even need a clinical trial. Maybe government insurers, private insurers, we should be gathering these data and using them to make these decisions. And now, of course, as we bring liquid biopsies in and molecular studies, ctDNA, All that needs to be incorporated into the regular health system.
When actually patients come and ask us, so what have you done? What have you seen over the last X number of patients? And we should have that answer.
Absolutely, absolutely.
Well, when you mentioned the role of kind of insurers and health delivery organizations, what is their role in contributing to that kind of real world data? And how do we kind of bring everyone to that table?
Well,
I was just saying, like, we are actually do a lot already with, say, Medicare data. And so there have been studies that have taken advantage of that system in terms of longitudinal outcomes, and that it turns out to be robust. The same thing in terms of private health plan data. One of the challenges, though, is just patients or people, I should say, going from one employer or one health plan to another. And so one challenge we have is, what's a unifying health code, essentially. We actually have it. It's called a Social Security number, but we don't use it here. Places like Sweden and Denmark, they have that unifying code.
We can take advantage of what we have. So, we generate, data that's pragmatic all the time in the hospital. I went to a meeting recently where a group of anesthesiologists talked about how they're constantly doing pragmatic trials. They're randomizing between one drug or another in the hospital. These things should happen right on the floor of the hospital. Like in cardiology, you do trials, you enroll patients, TIMI protocols, things like that. I remember when I was a resident, I was participating in clinical trials and I didn't even know it. So we should be trying to get these studies ingrained within the hospital and collect these data, and we don't do it well enough.
And one other thing, health plans actually also they benefit from having better evidence in terms of making decisions, what they're going to pay for and what's the value of that. They sometimes aren't as integrated as one would like. And so how can we do that is an important question.
I would say, some of what we're touching, there's a number of tension points here for us at CMS, particularly for these novel therapies. People look to Medicare, the industry looks to Medicare decisions, which has a huge influence, a ripple effect on whether it's going to be covered by other insurers, other plans. But that often puts CMS in the position of having to make a decision before, in many cases, the evidence is robust, but we are CMS. We do have a robust clinical presence, many physicians, nurses, other providers. But at the end of the day, we're not the researchers. We're not the ones who develop the groundbreaking science. We are making decisions in the absence of clinical guidelines or without established guidance or evidence. And so that often puts CMS in a very difficult position of having to move, and although it's very uncertain terrain. And then also it has what we decide in Medicare has major implications for Medicaid. And so I think, as you touched on, certainly in Medicare, we can decide how we're going to cover it, but what does that mean for the states? Or what does that mean for our partnership to cover our lower income populations and others who are Medicaid? So it's a very difficult issue that we're talking about, particularly in the context of novel therapies and treatments that are just now just starting to hit the market, and in many cases with very high price tags.
So if we were to try to address that, we've already heard about some really innovative federal partnerships that are trying to link clinical research with other parts of the ecosystem, and maybe that would provide some additional information about some novel therapies. But if you were a manufacturer and you were trying to think through how they could best work with CMS, or maybe to address the outcomes that will be what matters most to you, what would you advise them to do?
I think some of that we've touched on, even with our new TCET pathway intervention, where we are doubling down on coverage with evidence development, but we have to do our part. So we are proposed updates to our CED guidance, and we put that up for comment. We anticipate finalizing that. These are the expectations that we will have when you come to us, but also what steps can we do to make it easier? For example, how much earlier can we, in this case, we said, if you are about a year from anticipated approval by FDA, come talk to us. a year in advance, 6 months for sure in advance. So we can look at the evidence together and say, this will work for your clinical trial for FDA, but if you want coverage at CMS, these are the additional evidence gaps that remain, and that we have to agree upon what is the plan to fill these gaps. And if you go through these steps through our new pathway, we will commit to opening a national coverage determination when your product is approved by FDA, so we can start earlier. We are committing to deadlines, so you're not kind of in CED purgatory, as some people describe it, for many, in some cases, many years, but that we can agree that if you hit this milestone, we will re-review. When you hit this milestone, we will then again look together and make an earlier decision. And so I think that in this context, with that new guidance, which even though that the TSET pathway is focused on breakthrough devices, certainly as we start to pilot, roll that out, that will have influence on how we look at other items and services, other treatments that come before us as well. But I have to emphasize again, our coverage and analysis group is a very small, a very small and mighty team, but a very small team. This is not the NIH. This is not 27 institutes and centers sitting. We are reviewing the evidence, the best evidence that we have available from the industry and from external groups. We don't have our own mandatory funding stream. It's a very difficult and laborious process that we support through CCSQ. And to the extent that we can partner more with our colleagues at FDA, with NIH, with CDC, with our external stakeholders, the better that, the more we'll have more confidence that we've gotten our decisions right.
One thing that's interesting challenge though is like, for getting a drug or device approved, there's definitely a more predictable pathway in terms of regulatory approval for FDA, although you have variation across the world in terms of what's the evidence needs and approvability. For CMS, what the plan there is more transparent and predictable. When you get to the commercial health plans, it's much more variable and much more opaque. And so a lot of the industry, they don't necessarily know what's going to be needed at the end. And so that's a much harder thing.
Yes, please.
Mary Klopman and I were speaking about an initiative at Duke led by Swati Shah about a large-scale genetic analysis of the patient community. You mentioned, Mary, 80% of folks living in Durham are patients of Duke Healthcare. The only other place on earth where that's happening is England, where Genomics England is sequencing 50,000 newborns every month, and they're putting the DNA sequence into the electronic healthcare record. At the same time, they've established via the MHRA an accelerated regulatory path of engineering and genetic medicine if the mutation is severe. But the reason I stepped in is just to highlight just one specific point. At this point, we are living already in a world where analysis of a patient's genetic information can reveal a genetic vulnerability that will manifest itself at some point as a disease with severe morbidity and mortality. And in the age of CRISPR, frankly, the entire human genome is a druggable target. Bring it on. We will liver, lung, blood, sensory systems, rapidly skeletal muscle and heart are coming online, immune system engineering, et cetera. So I think with respect to how you reimburse where, as you pointed out, how do you pay for a therapy where it's going to take years to find out if it's actually worth that price tag? One approach could be what's currently happening at the federal level, which is where the National Institutes of Health funded a number of academic groups, and I say academic in quotes because it's not like, dusty-haired faculty in front of chalkboards writing unintelligible equations. It's very, very translational. So there are 5 disease teams that have been funded by the NIH, the Somatic Cell Gene and Genetic Consortium, including one led by Jennifer Dowden at the Innovative Genomics Institute, to take 10 diseases, CRISPR, all the way to IND on the federal dime in platform mode, which you alluded to. And the reason I bring this up is this will allow, because we're all funded by the federal government, to address the problem of siloization. By statutes today, biotech number 1 and biotech number 2 take themselves through regulatory approval, interactions with the agency in a way that's completely firewalled. The agency has no ability to share information. What I'm hopeful will happen in these academic centers of excellence. As more and more of these trials begin, we learn more and more about what actually matters in terms of real world evidence sharing, and we will be able to share that information. And as that information emerges, like what are the biomarkers of success for a CRISPR therapy for chronic obstructive pulmonary disease or non-alcoholic steatohepatitis, what I'm hopeful is we'll give the payers more information to determine from early stage biomarker data, oh, wow, yes, this is a curative one and done versus, you know what, it's going to wane to 40% initial outcome. So what I'm arguing for is really hybrid models for how we develop medicines, where we kind of start to erase the boundaries between traditional for-profit developers of medicines, you know, siloed with their regulatory interactions, and then again, siloed with their interactions with the payers as to is this 4 million or 500,000? And frankly, a new world where centers like Duke, you know, sequence their patient community, identify individuals at risk of CRISPRable disease, and then they get CRISPRed in smaller stage trials, exactly as you described. But that evidence has become now common knowledge. It becomes the rising tide that lifts all boats.
So you're mentioning a cultural change, and we've heard that a lot today about, you know, that we might be comfortable in silos, but new students aren't, and that we need to start having some federal coordination in a way we've never done before. But you know, clinical trials are a machine. I'm not looking to say
They're a broken machine.
But they, you know, well established within academic centers, and you know, how do we incentivize this type of change that everyone here is speaking about, so that it's not just projects that are showing great promise, but maybe will not go to the next step? How do we make this a cultural change that really does this reimagining that we're talking about?
Well, I'll just, you know, start off with a few things here is that we really have to rethink the end-to-end process. So if we have all these busy clinicians and these healthcare systems that are already stretched in terms of taking care of the population, part of the incentive process has to remove all the barriers that we've added. So the example that you're talking about, that trial, how you had all these ornaments, things that have been added over the years for the typical cancer trial. The same things happen in other areas, cardiovascular. One of the major trials in cardiology was 3 pages in the 90s that led to an FDA approval. Now it's 300. And every step of the process. For consent, for example, for participation, most people, 98% of people, don't know there's a trial out there for them. And even if they did and got approached, they get overwhelmed by a 25-page consent. And that's called informed consent. It's not an engaged consent. And so it doesn't fit on your phone. So we have to re-engineer the whole process. And then for the everyday clinician, we have to make it valuable so that they have this interest. They want to help bring new therapies to their patients, but you can't have this overburdensome system. And so they have to remove the barriers and also have them recognized as part of their day. How do they get rewarded, reimbursed, et cetera?
Yeah, I couldn't agree more. And I was going to focus on, he said the word hybrid.
Yeah.
And I like that. And I think we need more of that, thinking out of the box. So, you know, in cancer now, in our phase 1 clinic at Yale, you know, we enroll the patients in the community. We have 15 community sites, but then they come to the main center to get the drug, but then we do as much follow-up care as we can in the community, a hybrid model. And we've actually, as you know, following up on some of the things we heard about this morning, we've gone out to the community to understand what are the social determinants that are keeping these patients from going on trial. So that's one way to do it. And I love what you're talking about, collaboration. And, you know, it'd be great if there was a pre-competitive collaboration among companies, but the public-private partnerships, getting groups to work together, I think that's important because I'll just speak for the area I know best, cancer, 90+% of patients are treated in the community setting. They can't make it to any of our centers. They don't have the wherewithal. They don't have the family to take them. So we have to have a high-touch trials at the point of care. And we can do that by making it more simple, cheaper, and it has to be something that the general, you know, not every trial, but some of the questions we're talking about, the more pragmatic questions that the general physician of whatever specialty he or she is able to run.
Okay, great. Well, we've heard a lot about federal kind of partnerships, and I do want to kind of love to hear the CDC example if we could, but just wanted to see, is there any other areas where you see from a national level that there could be opportunities for better collaboration or ways to enhance kind of an infrastructure for our clinical trials?
Oh, well, I'll just say there are a couple other things that should be considered. You know, when we went through COVID, it was like the administrative bureaucracy just went away. There was like a safe harbor. And so we didn't have to go through one-off negotiations for every contract, for every IRB approval, et cetera. And so there was this kind of safe harbor to do good for the world. Everyone joined in. And right now we've gone back. Yeah. So we've gone back. And so there are ways to do that. And so and there's actually a lot of ways that we shouldn't repeat the process over and over. So for example, any kind of clinical trial to get a site qualified, get an investigator qualified, they go through the same process that they did the last time, and the time before that, and the time before that. There's not a TSA pre-check line. Like that is what we need, and we should be able to do that.
Great.
I couldn't say it better, but except that, Epic orders, they don't even transfer from one hospital to another. You've got to rewrite those. It's not simple. The contracts and even central IRBs that we've been talking about for what, 20, 25 years, still don't work as well as they could.
Great. And Dora, do you have any more to say about this?
Oh, yes, as much as we certainly on the biomedical side, we focus on our partnerships with FDA and NIH, but I do think it bears noting that CMS and CDC are increasingly working closer together. In part, as one example, CDC is, they collect information from hospitals, other entities through their NHSN, their National Health Safety Network. We saw that through COVID. They were collecting rates of COVID, of course, but also increasingly look at other rates of other respiratory illnesses. But they're also combining that with hospitalizations and other safety events information. They are sharing that data with us, and we're using that data to inform some of our quality measurement work. And I think that's just an excellent example of where hospitals or other clinical sites in the community, they're collecting that data once by way of CDC reporting it once. And then we're able to leverage that, minimizing the burden and being able to use it across a number of different programs and policies, and not just for CCSQ quality measures, but potentially through for others is CMS. And I do think that's very much, again, it's very much the picture, the image that Monica was describing, and how can we do this once and then use the data in multiple different ways, and trying to, for us, thinking through, again, what data is CDC collecting that we can use to help it determine the outcomes and other for other evidentiary purposes. So I did just want to mention that, because as much as we focus again on FDA and NIH is our BFFs at CMS for evidence generation, CDC increasingly is becoming a very valued partner as well.
That's great. And did I catch you off earlier?
I could go on about CRISPR until tomorrow.
Tell us more.
I will just say one specific thing. I think ultimately CRISPR has to become the standard, the practice of medicine. The Jennifer Doudna Nobel Prize was for the fact that you can make a CRISPR medicine using rules that I have successfully explained to my 8-year-old daughter. We've never had a technology for one and done human genetic engineering that is as simple to deploy. So I think that national level coordination, I think the United States is uniquely positioned to do that. Honestly, I think England, United Kingdom, is the only other place in the world where that could happen. But national level ability to integrate data across how early stage clinical trials are done, to share the data with the agency, with the FDA, of course, but ultimately, as soon as possible, deliver the data to CMS to say, for this category of syndromes, again, thank you. I think you said it very, very well. It's the LNP to deliver 2,500 infants every year, the biomarkers for welfare. Like, the sooner we can start aggregating these data, the sooner we can learn what matters and what doesn't, and how to make the COGS of these medicines and these trials cheaper, so that we can basically make the N of rare into the N of common. I think now is absolutely the time. The clinical proof of concept is in, the technologies are there, the manufacturing is there. Honestly, last thing I'll say, I don't know what the COGS of the Moderna or the Pfizer vaccines for SARS-CoV-2 are, but I know, here's a number, Pfizer made GMP 1 kilogram of messenger RNA. And I know there are many molecular biologists in the room. Just wrap your head around that point. 1 kilogram of messenger RNA. That's 4 billion doses. That's the same technology you used to deliver CRISPR to the liver. So CRISPR is manufacturable at planetary scale today. The question is, what are we going to do with that? And I think this national level coordination, vertically integrated, is what to do.
Okay, thank you. And I want to also just, before I know we're running out of time, but we've talked a lot about kind of moving beyond maybe the traditional settings for clinical trials, and you have some really great examples here. And I've heard Monica speak of it in the past about moving more into the rural communities. And but we also acknowledge that running clinical trials is expensive, and we're asking a lot of burden clinicians, perhaps, if we're asking them to do point of care. So Adrian, you've run really big platforms and really big clinical trials. So how do you take those learnings and how do you help other sites that say, I want to be part of a clinical experience of clinical research? How do you make sure that they have the resources they need, and the expertise and just the space to know that they can do that well? And then likewise, Roy, how do we take the example that you have and make that applicable to other communities, other disease areas, moving this all forward?
I think, one special thing now is like let the clinicians in those settings focus on what they do best, which is engagement of patients and people. People trust them, and so let them do that part. All the rest of it can be done in the background. You could do a centralized virtual consent. Someone can be in the waiting room or right there with an iPad, FaceTiming to go through things. That is getting more and more automated. So you can have actually semi-automated chats so that people can have their questions answered in a live way. The drug delivery, there's this thing called UPS, FedEx, Amazon. Those things can be delivered. You can even get lab tests remotely at home. So there are many things that can be done in a more decentralized way. And so for the rural communities, be able to let clinicians do their best with that engagement, take all the other stuff out of what they need to do so they don't have to rebuild or build infrastructure to do so.
Great.
Well, you have to get the innovation and the new drugs to the patients as quickly as possible. Clinical trials are the way to do that. In oncology, we already have a pretty good clinical trials network, large cooperative groups, but even more vibrant are the smaller community groups. And, when we were running these trials, the Lung Master Protocol and then the Pragmatic trial, which is on now, it's open at 500-600 sites because it's easy to open because they already have the existing infrastructure. Many of these groups already have small grants that help them out. In fact, in some of these public-private partnerships, you can add extra money to sort of induce, but that helps them to maybe hire some additional staff. And again, by making the data collection minimal, by making the consent form less burdensome, by making the protocol much easier to read and comprehend, there's a lot less work involved. And you have to pick your questions. So you might not do the newest phase 1 KRAS inhibitor, which might have 4 or 5 unknown toxicities out in the community, but you can bring it there quickly once you know that it's safe. So I think that's the only way to do it. You have to, rural communities, if you look at the map for the Pragmatic trial, it looks like the map of COVID around the country, and actually that was actually very interesting. During the height of the pandemic, the trials continued to accrue because they were open throughout the country and patients could go to whatever sites, as things varied from state to state, it was open at the point of care. And I think it's doable, but it does require leadership, commitment, and resources, but less than you would think if you write the trials properly.
We had the same experience. So a trial that the requirement was to be 75 years and older, though, around healthy aging, very large scale trial. It was launched during COVID. That was not the plan. It actually worked because it was fitting the patient's life, all remote, drug delivery, all remote.
I worry that some of the remotes going away, that's become a little bit of a problem. The state to state barriers and so forth have become a bit of an issue. We might need some legislation for clinical trials that we can allow for it. Because when you live in Connecticut, where you have 4 states and on the border, it becomes a problem.
Okay. Well, I'll end it with kind of that forward facing, as much as I love to give Mark new ideas or to give my staff more work, I would love to hear from each of you briefly about where you think Duke-Margolis should really focus our efforts as a way to build a robust, sustainable, diverse clinical trials, evidence generation infrastructure. Where do you hope that we go?
Cross-functional integration, which is exactly what this forum is. I've never been in a meeting where the director of the NIH spoke just before, the head of Medicare. So I think that problems of the scale cannot be solved by individual silos. You have to have a vertically integrated team. So you have the Avengers, right? So multiple superheroes with non-overlapping superpowers. So thank you for bringing us together. Please continue doing exactly that.
Great.
I think one of the strengths of the Duke-Margolis Center is translating much of what we hear, the expertise, the evidence, the science, into policy solutions. And so that's where I encourage you to continue to focus. And so if we're hearing, for example, that we need to focus more on fit for real world evidence or pragmatic trials, how can CMS support that? What do we need to change about our policies or our regs that could advance some of the ideas that we're hearing in the panel? I think that's one of your strengths and one that we find certainly just invaluable.
Great, thank you.
Help promote and continue the collaboration in these pragmatic trials. We're in jeopardy. There was an article in JAMA this week that was critical of accelerated approvals. And that could be an issue if that went away. We need to continue to push to get drugs approved earlier, reimbursed so that we can study them in these pragmatic ways.
Great, thank you.
And also see facilitating national policies that really are eliminating or reducing the barriers for point of entry for clinical trials and harmonizing what people need to accomplish across all the state boundaries or the interagency boundaries.
Excellent. All right, with that, I would like to thank this panel and really appreciate all of you. Hey, I'm going to turn this over to Mark for concluding remarks.
Yeah, I'd like to thank the panel as well. And you all will be very pleased to know that I am not going to try to summarize what you heard here today, just like what they said. But I do want to say how much of a privilege it is for me to be part of this very special kind of gathering that brings together so many policy areas, scientific areas, lived experience, real world perspectives, practical policy strands on how to improve health, innovation, access, and affordability. So thanks to all of you for being here today, either with us in DC or so many of you who are with us online today. Thanks to our conference speakers for a wonderful day of fresh, innovative, and I think potentially achievable ideas for effective policy reform. Thanks to Bob Margolis and our advisory board, who have been so critical in guiding and supporting our efforts now as a Duke Institute. And a special thanks to our sponsor today, Alexandria Real Estate Equities and Lynn Zadowski, another long-term partner. And then a couple more special thanks. One is to the people who brought this conference together, the Duke-Margolis team members, and really this is like all hands on deck, but I want to give a special call out to Luke DeRocher, Hannah Vitello, Patty Green, Rob Saunders, Marianne Hamilton Lopez, Rebecca Whitaker, Trevin Locke, Cameron Lemke, and Morgan Romine, the glue for this Duke-Margolis conference, for all their planning and preparatory work. All of this is, yes, well deserved. All of this is built on a foundation that includes our research funders. We talked about how we try to build up these long-term areas of expertise, networks, trust, and the foundations and supporters that have been with us for the long term, the Gary and Mary West Foundation, Commonwealth Fund, Robert Johnson Foundation, Arnold Ventures, Kate B. Reynolds Trust. I could keep going, but they make a big difference. So do our donors, the people who believe in us and believe in what we can do together in new ways at Duke. And a very special thanks to our research team, our faculty, our students, who every day combine heart and expertise and a commitment to work together to improve health for all. This is not easy work, But boy, I'm inspired by the ability of everyone around us to come together. And that includes our collaborators and partners who add to this day-to-day work. We've heard a lot about team sports today, but the Duke-Margolis Research and Education team and all of our network and partners, that's a really special and unique team. Thank you all for making it possible, and thanks in advance. There's a lot more to come. Thank you.